is the factor or whether it is the psychological barrier. So these are the three barriers: knowledge barrier, cost barrier, and psychological barrier. First, initially, we have to identify where is the barrier. If there is psychological barrier, then we have to spend time with the patient. We have to sit with the patient and explain each and everything about the insulin. What are the benefits of insulin? What are the types of insulin? How proper insulin techniques should be explained to the patients, timing should be explained to the patients, and when cost is the factor, then the cheaper insulins like human insulin can be prescribed in place of the newer insulin analogs. And when knowledge is the barrier, then it is our job or it is the job of certified diabetes educator to teach each and every aspect of insulin to the patient. So in one study, it has been found that the four most important aspects which should be focused by a physician to solve this insulin barrier at the patient level is: first is the demonstrate the injection process to the patient. Second is the explain the benefits of the insulin to the patients, and take any decision in collaboration with the patient. In each and every decision, patient should be involved, and every decision should be taken in consultation with the patient. And the various myths which are associated with insulin, it is our duty to dispel that myth. So these are the four most important factors to basically to solve the barrier at the patient level. So every solution has the main key is the effective conversation. We have to explain each and every aspect of the insulin to the patient, and if you spend the time, most of the patients ultimately will ready for the intake of the insulin, either initiation or intensification of the insulin therapy. So there are various myths associated with the insulin, like taking insulin means I have failed to manage diabetes with diets and tablets. This is one of the main myths associated with the patient, and the felt of guilt is there along with the patient. So you have to explain that diabetes is a progressive disease. In spite of very good treatment, in spite of diet control, in spite of very good control by diet, exercise, and oral hypoglycemics, after 10 years, after 15 years, after 20 years, there is a stage when all the beta cells has been lost and insulin is needed. So not only it is your fault, also it is a natural history of the diabetes is such that diabetes is a progressive disease. So ultimately, most of the patients require insulin. So this should be explained to the patient. Another myth is taking insulin makes it more difficult to fulfill my responsibilities at work or home. So you have to tell that taking insulin doesn't disturb your actually responsibility either at the work, either at the office level or at the home level. So you have to just explain, and the starting basically depending on the patient's work profile, we can prescribe the various types of simple types of insulin regimen like twice premix insulin or basal bolus regimen in place of the complex insulin regimens. So I am afraid of injecting myself with needle. This is one of the concern of the patient. So in this case, you have just explain the proper insulin technique in front of you, in front of the patient, and just inject one sort of insulin by the doctor to the patient, and explain that there is no difficulty. So that is one of the main, that is one of the way of dealing with that. And injecting insulin is painful. So injecting insulin is painful, and for that we have to explain that we have to show the syringe to the, we have to show the needle to the patient that the needle of the insulin injection, either pen needle or the syringe needle, is very small in size, it is very thin in size, and it almost causes negligible pain or no pain. And even the pain caused by the syringe needle is more in comparison to the pen needle. So pen needle is even finer and smaller than the syringe needle. So by taking insulin with the help of the pen, it is the pen can be minimized. Taking insulin increases risk of hypoglycemia. Yes, there is a risk of hypoglycemia. There is no doubt with the insulin therapy, but this risk can be minimized by the proper diet, proper exercise, and the proper insulin, and with the use of the newer insulin analogs. So alleviate fear of hypoglycemia. It is bound to happen, hypoglycemia, when we prescribe insulin or any insulin secretagogues type of oral hypoglycemic agents. When we try to control blood sugar very tightly, then there is chances of development of hypoglycemia. It cannot be avoided completely, but our target should be, it should be minimized. And if hypoglycemia occurs, in spite of all the precautions, then treatment of hypoglycemia is very simple. Rule of 15 should be remembered. 15 gram of carbohydrate should be taken immediately whenever blood sugar is less than 70 milligram per deciliter. And after taking 15 gram of carbohydrate immediately, wait for the 15 minutes, and if symptoms doesn't improve, then take another 15 gram of carbohydrate, and after that, the whatever the food available in the home to the patient, that should be taken. So managing hypoglycemia is also very simple, but it should be avoided. But if occurs, it can be managed very easily by the patient himself or herself. Insulin causes weight gain. I have already discussed that the weight gain part can be managed by the proper diet, exercise, and with the help of other drugs like SGLT2 inhibitors or GLP-1 receptor agonists, which are actually causing weight loss. And the weight gain caused by the insulin analogs is less in comparison to the human insulin. So taking insulin means life will be less flexible. So for clearing this doubt, we have to simply explain all the things to the patient and prescribe simple regimens to the patient. I have already discussed this. So one or two slides on the focus on insulin access. So this is basically problems at the healthcare delivery system. Okay? So on the insulin access, basically, there are only few companies, mainly multinational companies are available with the insulin, or especially with the insulin analogs, and they are dominating all over the global market for the insulin availability. Only few Indian companies are available with who came with the insulin. Only Biocan and Lupin, these are the two companies who came with the insulin. So basically, and in various studies, it has been found that in countries like India and Nepal, or the poor socioeconomic conditions, countries where socioeconomic condition is not very good, the availability of insulin in the remote places are very, very miserable. Even in our countries, the insulin is not available even up to the level of the block. For taking insulin, patient has to go to the district headquarters to buy insulin. So the insulin availability is a concern, and even in the metropolitan cities like Bengaluru, it has been found that there is one study in which they have found that the availability of insulin in Bengaluru is less in comparison to the WHO targets. So, to addressing insulin access challenges, dominance of non-Indian companies are there, and increasing market competition is very much essential, because insulin analogs are available with the multinational companies, so it is very costly. So it is not cheap. Every patient cannot afford the insulin analogs. So and since they are, that's why we are more prescribed the human insulins. The efficacy wise, there is no difference between the human insulin and insulin analogs. Only is the side effect profile is of insulin analog is slightly better in comparison to the human insulins. So, and the policy decision should be taken at the government level so that insulin is available, insulin will be available even at the remote places. So, to summarize, it's time to bridge insulin inertia. Poorly controlled diabetes leads to increased risk of developing micro and macrovascular complications. And frequent insulin injections are burdensome and inconvenient not only to the patients but even to the physicians also. And people with diabetes and physicians prefer fewer insulin injections to reach glycemic goals, and insulin availability remains low globally, particularly in the low and middle income countries, leading to accessibility issues which can be addressed by the governments. Thank you.
Thank you. Session is open for question from audience. If you have any question, any doubt, or any remark, you can give your.
Kumar sir is on his way. Till then, we will start the felicitation of two of our speakers. So I request Professor Dr. Ashish Kumar Vishwas sir to kindly felicitate Dr. Nirav Kumar sir. Now I request Professor Dr. Sudhir Kumar sir to kindly felicitate our speaker, Dr. Ved Prakash sir. Thank you, sir, for this informative session. Now I request Professor Dr. Sudhir Kumar sir to kindly felicitate Dr. Ashish Kumar Viswas sir. Professor Dr. Ashish Kumar Viswas sir to kindly felicitate Sudhir Kumar sir. Chairs, so he's coming.
Who will talk about how to prevent diabetes or how to go for the remission in diabetes. So we will wait for a few minutes and he will.
Yeah. Sir, can I have question? Sir, it's for you, Dr. Ved.
Yeah.
I'm Dr. Reye.
Yeah.
You said that in India, this insulin administration is delayed for around 8.8 years, some data you have shown.
Yes, ma'am.
But do you recommend start of insulin early in therapy? Because few years back that was mentioned that insulin should be started as early as possible. And again, there was a delay. So what is a starting point and when one should start?
Ma'am, very good question. Insulin can be started even at the time of diabetes, diagnosis of the diabetes. And there are various studies available in the literature which clearly show that if insulin is started at the time of diagnosis, then chances of good control and even chances of development of remission is more when insulin is started at the time of diagnosis. So insulin can be given even at the time of diagnosis or whenever there is catabolic symptoms are predominant, like polys are there, weight loss is there, patient is losing weight at that time, and there are various indications in terms of absolute numbers, like if HbA1c is more than 9, then we can start insulin. If fasting plasma glucose is more than 250, then we can start insulin, even at the time of diagnosis also. Yes, ma'am.
Ira Desai, what is the current trend of keeping the glycosylated hemoglobin? It is proposed to be less than 6.5, but nowadays I think it has already been said that you
yes,
can, increase it.
Yes, ma'am.
It can be at a little higher level also. So
Yes, ma'am.
what is the actually cutoff? Because as a medical person, many of the patients, they ask us.
Yes, ma'am. The there are various recommendations by the various authorities. Like according to the American Diabetes Association, HbA1c should be either equal to or less than 7.
Okay.
According to the American College of Clinical Endocrinologists, it should be less than or equal to 6.5. But that criteria is basically for the adult patients, adult healthy patients. The HbA1c criteria can be changed according to the patient. If someone is 70-year-old or 80-year-old or 65-year-old and having already developed the various diabetes micro or macrovascular complications, having multiple organ failures, in that case, there is no meaning of achieving HbA1c 6.5 or 7. In that case, our target should be between 7.5 to 8 or even 8 to 8.5. So depending on the age, depending on the comorbidities, depending on the other issues, the HbA1c criteria can be changed. But the main aim, the one of the negative point about the maintaining HbA1c less than 6.5 is that for maintaining HbA1c below 6.5, hypoglycemia bounds to happen.
Okay. Yeah.
So it is always better to maintain between 6.5 and 7 in a healthy young adults.
Okay.
And HbA1c criteria can be changed, like between 7 to 7.5 is around in age 65 years, 7.5 to 8 is 70 years, and that is.
Suppose if there is also comorbidities, this
Yes.
is very common, hypertension and all.
Yes.
So even a healthy person, as it is active, physically active, professionally active, and having comorbidity, but the glycosylated hemoglobin is touching 7. So can he continue with the same treatment, or there is a need to add any other drug?
Yes, ma'am. If HbA1c can be achieved safely below 7, and there is no chances of, there is no increased risk of development of hypoglycemia, then target can be lower down. But after addition of drug, if there is chances of development of hypoglycemia, then even 7 is better.
Okay.
7 is better. At any cost, hypoglycemia can be avoided because hypoglycemia is a very dangerous thing. And in various trials like ADOPT trial and ACCORD trial, it has proven that hypoglycemia actually can cause increase in the cardiovascular mortality. So our main aim should be to avoid hypoglycemia.
Yeah.
And if HbA1c 7 is very good, ma'am, there is no doubt.
Thank you.
Welcome. Yes.
Is well controlled. It is 7 according to you. But fasting is 182, PP is 231. Then what to do?
Actually, for reason, most probably the reason is that poor diet control and poor exercise or missing the drug in the recent past. Because average sugar is normal, HbA1c is normal, and fasting PP is high, it clearly shows that there is some problem either in the diet or exercise or in the drug in last few days, 4 days, 5 days. So we have to find out where is the problem, and then we can address that problem. There is no need to increase the drug, because by increasing the drug, there is chances of development of hypoglycemia.
Thank you.
No introduction, because he is a leading physician not only of Bihar state but in the field of diabetes. He is a leading physician of our country, and he will talk about how to remedy the diabetes, reversal of diabetes, and it is very hot topic nowadays. So we all will listen. Our star orator, Dr. Ajay Kumar sir.
Delegates, ladies and gentlemen, at the outset, my profound apology for being late, and thanks to Dr. Harihar Dikshit for giving me this opportunity to speak in front of top-ranking pharmacologists of this country. When we talk of reversal of diabetes, it's a very controversial term that you must appreciate. There are many people who completely castigate this word and abhor with the entire terminology of reversal. But I think it's possible to be somewhat sensible about this term reversal, and I'll tell you that the current understanding of type 2 diabetes is that this is a progressive disease where over time the beta cell function will decline, beta cell mass will decline, and every patient of type 2 diabetes will be on insulin treatment, come what may. Next decision. So what has happened that the pundits across the world have decided that we should be giving a specific names, because when you talk about reversal, it has a general meaning that you are talking about cure of diabetes, and that is certainly not possible because beta cells are programmed to die. A person will become diabetic only when he has a genetic predisposition to develop diabetes. And therefore, a better term is remission of diabetes, and we have very clear definition that if you stop the anti-diabetic treatment and achieve the target HbA1c of less than 6.5% for 3 months, we call it remission. And if you can demonstrate the same thing for 1 year, then you are certainly talking about diabetes remission in full, diabetes reversal, and if you can extend the same phenomenon over 5 years, I think that is something which is extremely laudable. When you look at the natural history of type 2 diabetes, there is a persistence of insulin resistance throughout the natural history of the disease, but there is a decline in the beta cell function. And pari passu with that decline in the beta cell function, first the postprandial blood sugar goes up, then the fasting hypoglycemia takes place. But I would like to draw your attention to the top column where you see a great window of opportunity. Before the development of clinical diabetes, we have the stage of obesity and pre-diabetes. If we can strike at that point of time, you can certainly reverse the process of diabetes, and that is what is the area of new research in the field of diabetes. And we can clearly identify that who are going to be the responders and who are going to be non-responders depending upon their intrinsic beta cell function. And as you can see here, the progressors will have extremely low beta cell function as compared to the non-progressors. How does it matter to clinicians like us? What are the determinants of beta cell loss? I think the first thing, obviously, genetic predisposition. And then if you do not keep your blood sugar under good control, there is glucotoxicity which will damage the beta cell function. And at the same time, the lipotoxicity, amyloid deposition, all these issues will perpetually keep on destroying the beta cell, and a stage will come where the oral anti-diabetic agents will fail and the patient will require insulin. So how can you talk about reversal of diabetes? You have glucotoxicity, lipotoxicity. I'll talk about a twin cycle hypothesis and beta cell dedifferentiation, and that will explain as to how we can actually embark upon reversal of diabetes. The prints on this slide may be very small, but this is a very simple slide. If you eat too much, if you are obese, then what will happen? On the background of the insulin resistance, the liver will not produce enough insulin to suppress the glucose. And therefore, there will be excess fat in the liver and excess fat in the pancreas, and pancreas will not respond to the food stimulus, and adequate secretion of insulin will not take place. On the other hand, if you look at the right-hand side, where the person is isocaloric, there is no obesity, there is no excess fat, then the liver will produce adequate amount of insulin to suppress the glucose, and the pancreas will produce adequate amount of insulin to take care of the glucose in the circulation. This looks like a theory. Do we have any proof of it? We have extremely elegant experiments which have been published in very reputed journals. And what we can clearly see, once again, this slide is very interesting. if you lose about 5 to 10 kg of body weight, there is a decline in the fasting plasma glucose, and along with that, there is a decline in the hepatic glucose output, and along with that, there is decline in the hepatic triacylglycerol. So very clear relationship that if you lose weight, you are decreasing the hepatic glucose output, you are decreasing the hepatic fat. Same thing happens in the pancreas lower down, as you can see here. The insulin secretion, the first phase insulin secretion goes up, and pari passu with that, there is a decline in the pancreatic fat deposition. On the right hand side, same thing, normal people, diabetic person, look at the suppressed insulin production, and when you lose weight, 1 week, 4 week, 8 week, and then later on, you see a coming back of the insulin secretion to a complete normal level, and that is what we are talking about reversal. As I said, not every patient is going to respond. We have non-responders and responders, and you can identify by the morphology of the liver or the composition of the liver and the pancreas. What am I talking about? I'm talking about liver and pancreas volume, fat, composition, and structure. When you look at the volume, in diabetics we know that the pancreatic volume will be less, and obviously the beta cell secretory capacity will be less. At the same time, when you look at the structure of pancreas, on the right hand side, you see very smooth contour of the pancreas, looks quite fat. That's perfectly normal pancreas. But look at the diabetics on the left hand side, there is irregular margin of the pancreas, and then look at the pancreatic fat content. Once again you find that there is a lot of fat sitting in the pancreatic cells. So we are talking about volume, we are talking about structure, we are talking about composition. All these things decide that whether your pancreas is going to produce adequate amount of insulin. Now the next question is, what are the interventions which can achieve this entire thing and address these issues of glucotoxicity, lipotoxicity, dedifferentiation, etc. that I talked about? Now the first attempt was made by Roy Taylor in UK, and he did a very elegant study only on 26 patients. And what he did, that he gave 830 calorie diet. And it was a very structured program, and within this 830 calorie diet, he ensured that the composition of food is adequate for human survival. And Roy Taylor himself was one of the participants. And what he demonstrated, that after a 12-week period, he will slowly reintroduce 400 calorie diet, etc., and slightly alter the composition from 61% carb to 50% carb and so on and so forth. We will not go into the detail. But what is astounding is the results that you see. 46% of the patients went into complete remission of their diabetes. And there were at least 24% of the participants who lost more than 15 kg of weight. And this was a revolutionary paper published by Roy Taylor, and then number of pathogenetic modules, how this loss of weight is helping, all these issues were taken into consideration, and we came to this conclusion that if you can achieve 5, 10 or 15 kg of weight loss, you can really bring remission in diabetes, and that opened the new vistas of research in type 2 diabetes reversal. When we talk about beta cell dedifferentiation, this is a very important new term. In normal people, in response to glucose or any other food, there is nice secretion of insulin, as you can see here. But over time, because of the progressive apoptosis of the beta cell, what we call is dedifferentiation, and beta cells do not produce adequate amount of insulin. But if it is redifferentiated, from dedifferentiation to redifferentiation, how? By weight loss, by some pharmacological agents, by insulin, many other things are available, and that can lead to redifferentiation. And you should not bother if there is just volume decline in the beta cell function, because by giving isocaloric diet or hypocaloric diet, what you can demonstrate is a clear increase in the insulin secretion. And the genetic markers of destruction of the beta cell, as you can see here on the right hand side in the middle panel, tall bar, that is an NGN3. That is a toxic cytokine, and if you can suppress that by adequate weight loss, you can see that the destruction to the beta cell is completely stopped. And this kind of reversal is absolutely amazing. Then the Banting lecture, which is one of the biggest lectures given in the field of diabetes and endocrinology, there the last speaker actually showed that there is a FOXO protein, and FOXO protein is clearly associated with preservation of the beta cell function. And if your blood sugars are perpetually high, then there will be a depletion of the FOXO protein. And if you can do some intervention to preserve the FOXO protein, then actually what you can do is to improve the C-peptide, improve the insulin secretion. Now, what are the agents available to change the FOXO protein and restore the FOXO protein function? This is not available yet in the market, but huge research is going on in this area of pharmacology. Modulating the FOXO protein to bring back the functioning beta cell in patients of type 2 diabetes. I talked about the progressive decline in the beta cell function and the role of chronic hyperglycemia in depletion of FOXO protein and destruction of the beta cell. And in the mouse model, once again, it has been clearly shown that if you restore the FOXO protein, there is very nice production, increase in the number of beta cell, functional beta cells, and restoration of the normal blood sugar level. That also brings us to the point that pharmacological agents like insulin, GLP-1 receptor agonists, etc., if given very early in the natural course of type 2 diabetes, can achieve the same end. Do we have any data about it? And look at the data with short-term insulin treatment. In my clinic, if a newly diagnosed type 2 diabetic patient comes whose HbA1c is more than 10%, fasting is more than 200, PPG is more than 300, from day one, I start insulin along with some oral hypoglycemic agents. Many doctors will not agree with this, but we have adequate amount of data produced over last 1 or 2 decades which show that in these cases, you do not need to give insulin for the rest of the life. You need to give insulin only for 1 week or 2 weeks or maximum 4 weeks, and you will see that the blood sugar is very, very normal, and you can withdraw the insulin and just carry on with the oral anti-diabetic drugs, or in few cases, even only lifestyle modification. So giving early takes away the glucotoxicity, the lipotoxicity, restores the FOXO protein, and gives you a normal beta cell function. And there is huge number of data with insulin treatment, which I showed you a number of papers. Can diet and exercise do it? Of course it can do it, but the problem is that the moment you stop diet and exercise, there is a relapse. And therefore, this is extremely important. Somebody say, sir, dawa mat likhiye, I will do diet and exercise. Of course, please do it. Achieve your weight loss of 5 kg, 10 kg, 15 kg, but then carry on. Just you achieve the weight loss and then stop doing diet and exercise, then it's not going to be beneficial at all. That came from the Look Ahead trial. Relapse following insulin therapy is much less, as you can see here, because what insulin did, it brought back the functional beta cell to recovery, and that's how, as compared to the diet and exercise Look Ahead, I can show you again, look at the steep decline. Whereas with insulin, short-term insulin, that decline is not that bad. What about the other drugs, pharmacological agents? And I think in this context, the biggest revolution is the availability of GLP-1 receptor agonist. Unfortunately, most of the GLP-1 receptor agonists were available only in the injectable form until last year, when your pharmacology department has done the revolution that they did some smart engineering with semaglutide molecule, which was initially available in injectable form. They did some very nice changes in the structure of the semaglutide and made it available by combining SNAC, which is an absorption enhancer, to produce the first large protein, the oral semaglutide, which has completely taken the world by storm. And if you are reading newspapers very carefully, in America and in Europe, semaglutide, the company is not able to supply the requirement of semaglutide. It is such a runaway success in the entire world. That revolution, and when you see the perpetual projection of the beta cell function for a very long time, I think this is the class of the molecule which is going to make a big difference. Because we know that GLP-1 receptor agonists cause glucose-dependent insulin secretion, glucose-dependent suppression of glucagon, huge amount of weight loss, 5, 10, 15%. I will show you a molecule which has just come, which leads to more than 20% of the weight loss. And I'll be giving you the data. But the most robust data of beta cell survival is from bariatric surgery. If an obese person undergoes bariatric surgery, we have 5-year survival data. That the not survival data, remission data. That patient was on 1, 2, or 3 oral agents, and after bariatric surgery, within 3 months, all the drugs were stopped, and for 5 years, patient did not require any oral anti-diabetic therapy or insulin. That is the beauty of bariatric surgery, but of course it is a surgical procedure, certainly reserved for a certain category of people, mostly who have a BMI of more than 35 or more than 30 if there is concomitant cardiovascular or chronic kidney disease. There are other emerging therapies like gas-filled intragastric balloon. Last month I was in America in San Diego ADA conference, and there they have found out a beautiful procedure where they are doing a resurfacing of the duodenal mucosa, and that is completely curing patients of type 2 diabetes. And that is now in very advanced stage of the trial, and possibly that will be another big change in the landscape of treatment of type 2 diabetes. Fecal microbiota transportation is another technique, but we will not go into the detail. And islet transplantation is not in the realm of imagination. Islet transplantation is now taking place in all the big centers of the world. Of course, it's a very challenging procedure, very demanding procedure, very expensive procedure. So it will not be applicable to run-in-the-mill patients of type 2 diabetes. And we have to look at the drugs. And in that context, I will finish my lecture by giving you the example of this dual GLP and GIP receptor agonist. You know, until yesterday, we had only GLP-1 receptor agonist, liraglutide, dulaglutide, semaglutide, everything. Now we have this tirzepatide, and this tirzepatide is a dual receptor agonist. It is a GLP-1 receptor agonist and also GIP receptor agonist, and it went through the SURPASS phase 3 and phase 4 trials. And the astounding result, look at the data of this molecule. Majority of the patients achieved an HbA1c of less than 5.7%. with an average weight loss of 10, 15, 18 kg. Few patients actually achieved a weight loss of more than 20 kg. And you thought that this was the best. No. In last ADA, last month, we heard that now we are going to talk about triple agonist. And pharmacologists know much more than me that you will now have a GLP-1 receptor agonist, a GIP-1 receptor agonist, and a glucagon receptor agonist. All three combined together, and the initial results, phase 2 trials have shown 25% weight loss of 25 to 30 kg with this triple receptor agonist therapy. So you can imagine if you achieve that kind of weight loss, the entire fat deposition in the liver and pancreatic beta cell will disappear, and beta cells will come back to life, and certainly that will be a great thing for our patients of type 2 diabetes. So ladies and gentlemen, today we must appreciate that in spite of our original understanding that type 2 diabetes is characterized by inexorable loss of beta cell function, I think that perception is a pass. You should know that today you can prevent type 2 diabetes provided you do the lifestyle intervention, use GLP-1 receptor agonist or dual agonist or triple agonist in the right kind of patient, give insulin for a short period of time, and then if few patients need bariatric surgery or islet transplantation and so on and so forth. But you have number of avenues to actually reverse the process of declining beta cell function, and if you do that, I'm sure many patients of type 2 diabetes will achieve remission, and that will be absolutely wonderful for our patients of type 2 diabetes. Thank you very much for your kind attention, and I'll be quite happy to take up any questions.
Is semaglutide, because as you already mentioned, there is a significant weight loss. And I think a clinical trial, multi-country clinical trial is ongoing. There is a fear that this drug can be misused as an anti-obesity drug.
Oh, that's a very interesting question. Now that problem is over, because the makers of semaglutide, the company Novo Nordisk from Denmark, what they have done, that they embarked upon obesity trial. And the obesity trial is called the OASIS and Pioneer 6 trial. So what they have done in Pioneer 6 trial, they have used semaglutide, not the anti-diabetic dose of 3, 7 and 14 milligrams, but they are using 25 and 50 milligram of semaglutide.
Correct.
And in the Pioneer 6, they are using in obese diabetic patients, and in OASIS trial, they used it in obese patients without diabetes. And they have demonstrated a huge reduction in the body weight, excellent control, and the same safety and tolerability. That's the beauty. Because normally we think that when you give GLP-1 receptor agonist, and particularly when you go beyond 7 milligram, there is likelihood of a lot of nausea and diarrhea, etc. But that's a different formulation. Again, thanks to pharmacologists. The 25 and 50 milligram of semaglutide is not the 3, 7 and 14 milligram of semaglutide. They have done some another engineering technique in the molecule, and they have produced 25 and 50 milligram. And there is no concern. There is no question of misuse. Now it will be an indication. All that we need, that on the basis of the OASIS trial result, FDA approval is awaited, and once it is awaited, then it will be used, not a misuse.
So it is going to be
Anti-obesity.
used as an anti-obesity
Absolutely.
rather than anti-diabetic.
Absolutely.
But there is always a fear of, especially we have seen sibutramine and all these drugs, which were anti-obesity drug, but they are associated with significant amount of suicide and depression. So these drugs are withdrawn now. So we have a fear that especially if this drug causes a significant weight loss, it might be used, but there is always a fear of psychological problems.
So
and
ma'am is referring
suicide.
to the molecule called rimonabant. I remember in the early 2000 we were using rimonabant live, right, left and center. That was an excellent weight loss drug, but unfortunately a lot of suicidal things happened and it was withdrawn from the market. But ma'am, that should not be the concern with the GLP-1 receptor agonist, because I remember I launched Victoza, the liraglutide of Novo Nordisk, in at least 20 countries of the world in 2009. And now we have 14 years of safety record of GLP-1 receptor agonist. Not one episode of suicidal tendency or mental disturbances have been reported with GLP-1 receptor agonist. So I do appreciate, phentermine, rimonabant. There were many anti-obesity drugs which were associated with psychiatric disturbances, but that is not the case with the GLP-1 receptor agonist. That is not the case with GLP-1 receptor agonist, and I'm sure with 14 years of background experience, it should not be a problem at all.
Thank you, sir.
Can I make it a point? Comment? This. I'm Professor Mehdi from PJ Chandigarh. You know that being a clinician, we always talk about very good efficacy, excellent drug compared to existing one. So it is in a control population. You are getting it. You're not getting the real world data. I'll give you an example because as a part of regulator, I cannot disclose it. There's one drug where we could find there are 30 dead. Then we try to investigate the matter. We went to the sponsor. We could find 93. My point is, take it as positive. If we not have done that investigation, then you would have seen that publication in Lancet or New England. It's excellent drug. Okay? So not to be taken, it's to be taken like a couple of days back also, yesterday also we are having a discuss that not disclosing that ADR, tolerability, okay? They say that data is not locked, it's ongoing. So you need to really look at that, what's the real world, okay? So, and along with that, since it is a chronic disease, how long, in terms of another 5 years and 10 years, that need to be looked at.
That's a very valid point,
yeah,
and I think in the world of pharmacology, we are already moving from phase 3 studies to phase 4, which are post-marketing surveillance and the real world data.
Yes.
And we have huge amount of data of real world studies with Victoza, that is liraglutide and semaglutide, and now oral semaglutide. We have just completed a real world study with oral semaglutide. And the other important thing is that in spite of the closed box of randomized control trial, which you very rightly mentioned, and the real world data, in spite of that, continuous pharmacovigilance is the key to the problem which he has raised. At any stage, for even 10 years after the introduction of the drug, you should be absolutely pharmacovigilant to ensure that this kind of events do not take place.
My point is, as a clinician, just think of it critically thinking.
We do.
Yeah. So,
say for example, in spite of 14 years of history of GLP-1, we are still talking in our conferences that the issue of pancreatitis with DPP-4 inhibitor and GLP-1 receptor agonist is still not settled. Even though clinically, as you said, we are very comfortable prescribing these molecules, but when you look at the data, you still find that we are not 100% sure that whether there is a causative association of pancreatitis with this group of molecules.
Definitely. But Yeah. Tell. No, I have
No,
been.
no, that was only found in the genotoxic studies in the animals. And in the animals, it was clearly demonstrated that they had very million-fold higher receptor count, and that's why there was that toxicity. Not in humans. Not a single case has been reported. But even then, we are saying that when you have a history of medullary thyroid carcinoma, you should not prescribe GLP-1 receptor agonists.
But my
Reversal is mainly related to the blood glucose levels and HbA1c. But when you start, means the patient, every time you may not get it as a new patient. It may be some patients already having taking some medication, and then they may go for this reversal with diet, whatever, insulin or. So what about that microvascular and macrovascular? There may be some abnormalities which have not surfaced yet, but at the cellular level they will be. Will there be reversal of those, or they may be different pathogenetic mechanisms?
Very valid point. And that is the reason when you look at the data of reversal with bariatric surgery, we have a clear differentiation when you divide into different 5-year slots. The maximum benefit was seen in those patients who had less than 5 years of history of type 2 diabetes. When you move beyond 5 years, 5 to 10 years, the benefit declined. More than 10 years, benefit was hardly there. So that's true, absolutely true. And in those 5 years to 10 years, what amount of microscopic microvascular damage has already taken place cannot be known by a clinician. You have early markers like cystatin C and microalbuminuria, etc., but that's not absolute. Unless you look at the microscope, look at the histological structure, you wouldn't know. Patient never knows that I had, he thinks that I have blood sugar of 300, I have no symptoms, I am fine. That's exactly your point, is extremely valid.
Now it's time to felicitate our esteemed speaker, Dr. Ajay Kumar sir. Now I request Professor Dr. Ashish Kumar Viswas sir to kindly felicitate Dr. Ajay Kumar sir. Thank you so much to all our esteemed chairpersons and respectable speakers for your presence. As much as we love diving into all this intellectually stimulating conversation, we also recognize the importance of nourishing our bodies and taking a break. So I would like to request everyone to move forward for a delightful lunch that awaits us. It's a humble request to all, kindly make your way back to the auditorium after lunch. Thank you so much.
Hello.
After half an hour, we will start our second symposium, second session.
Hello.
Dr. Birendra Kumar Singh, Professor and Head, Department of Cardiology, PMCH Patna. Dr. Ravi Vishnu, Additional Professor and Head, Department of Cardiology, IGMS Patna. Yes, he is in OT and will join after some time. I request our respectable chairpersons to please commence the session.
Drugs are Pandora's box. Many drugs. Mechanism of actions are also variable. In addition, every drug is in itself arrhythmic in nature. So we have to use it very judiciously and in a scientific way. For that, we have to understand the basic physiology or pathophysiology of the all antiarrhythmic drugs. Let us start. I invite.
Dr. Ashutosh Kumar, he is MD BHU, DM Institute of Postgraduate Medical Education and Research, Kolkata, and he is Senior Interventional Cardiologist cum Electrophysiologist, Department of Cardiology, Continental Hospital, Hyderabad, and former HOD Department of Cardiology, Narayana Medical College, Nerod. Former Additional Director in Cardiology, Care Hospital, Hyderabad. He is one of the 4 cardiac electrophysiologists from India who has the International Board of Heart Rhythm Examiners, which certified for the cardiac device specialist. He is certified electrophysiology specialist in audit cardiology. He has been facilitated with fellow from the World Esteem Organization, American College of Cardiology as FACC. He has more than 35 publications on his name in national and international journal, has published chapters in various cardiology updates and books. He is a life member of CSI, Cardiology Society of India, etc.
APCSI, EPSIT team for giving me opportunity and for a wonderful this conference which they are organizing, and it looks nice to see so many people who are inside this gathering, and a lot of dignitaries from all over the India as well as from the world. I heard that they have come. This is not my domain of pharmacology, but I loved pharmacology from very beginning, and my teacher, Dr. Hariyar Dikshit, he is there, and he was one of the pioneer person who has inspired to get through and through, because he was saying that particular time, if you are neglecting any of the things, when you are going in the practice, you will be having a very tough time. And those things are very crucial, because when I was doing my MBBS, it was 95 to 97 when I was in his trust. And those topics like anti-helminthic and anti-cancer drugs, which he was teaching that time, he was saying, you people are sleeping now. You will realize later on when the patient will come and complain the pain abdomen, and you will miss, and you will make a lot of diagnosis, and these medicines will make a difference. And certainly after getting in the practice, we know whatever the chapters are there in the pharmacology, it should not be neglected. And if you are not having the good grip on the subject, it will be very difficult to practice whatever knowledge you are having, but it is the pen which is right, and pen right with the pharmacology. So with those words, let me come on the topic proper, and that topic is electrophysiology. I know this topic will be a very, difficult to deliberate at, but since it is a guest lecture, I will take opportunity to discuss in one of the easiest ways, so that if I am able to reach to everybody in the language what you want to understand, I will feel that I have done the justice with the subject. So the focus area is for an electrophysiologist is the arrhythmia and heart failure. So when these two things are coming, usually either at the end or at the onset, they will be coming somewhere. Most of the time, if you are knowing or not, in India, electrophysiology is taken as a terminal branch, because it is mostly dominated by the interventional cardiologist. Anytime, any procedure, first angioplasty, bypass, and after that, if you have totally put your hand up, then the electrophysiologist roles come. And I will come how it makes a difference when we have to deal with the arrhythmia, because sometimes the medical management, when it has not worked well, then we will be called. Coming to the heart failure usually is the last procedure, means the last step in any disease. Means if you are managing well any disease, later on it will fail, and when failure comes, again the electrophysiologist role comes. And regarding the drug, devices, and EP study, you know that this is the core area where we usually practice, and the anti-arrhythmic drug, which during our MBBS time, we always pray to the God that anti-arrhythmic drug should not come as a long question, otherwise we will not be able to pass. But thank God, in our time, it was the anti-arrhythmic drug which has come. We have passed, but those days we can remember out of 50, I think 36, 37 students are not able to enumerate the classification also. So regarding the implants, what we do in electrophysiology, there are the 4 devices which we implant, and these devices are a bit different from the stent and the ASD, VSD, PDA devices because they are not endowed with any of the battery or circuits. So we call as a pacemaker, ICD, CRT, and loop recorders. So these devices are basically meant for any rhythm disorders, and when we are diagnosing, we have to give the treatment, and we will come how to decide which device has to be implanted. Other than the EP study and RF ablation, loop recorders are basically a ECG recording which is you are going to do for the diagnostic purpose. And these ECGs, what we are recording, it is live also nowadays. Now we are having the technology that we can implant the device and you can monitor from your home all over the world the patient rhythm, and that to a period of 3.5 years. So we call it injectable loop recorders. So in the picture you can see there is a device by name the Link. Yeah. So this is a Link device. So this Link device is having the capacity to monitor the heart rhythm for almost for 3 years. And it is what is called Wi-Fi connected, and it will give all the information what is happening. And we usually implant in a patient who is having atrial fibrillation ablated. We want to see whether the patient is having a rhythm disorder later on and how frequently. But in India, we are not able to implant because the reason of the cost. This cost around 1.5 to 2 lakhs. So very difficult to put a diagnostic device in a patient. And this device, we call it injectable. Just we have to put in the chest, inject it, and it will just lying in the skin of the chest, and it will give all the information regarding the heart beating. We use the word cardiac implantable electronic devices because all are having the circuits, all are having the batteries, and all are having some sensing and pacing functions. So other than the diagnostic, most are having the pacing function. That's why we call it CIEDs. So these are the implantable device what we deal. But before going into the what you call intervention, we should know where we have to intervene. So arrhythmia. So arrhythmia, as we all know that the most common presentation is palpitation. So palpitation, whenever it is coming, when you think that probably you are having a right ECG in which everything is clear, means tachycardia is there, PSVT there, VT is there, it is very easy to reach to the diagnosis. But when the patient is coming, most of the time those complaints are over. And that time it becomes very difficult to know whether it was an organic, means the patient is having disease, or it is a more psychological point of view, patient is feeling but the disease is not there. Other than there are 4 important complaints. One is the dizziness or fainting, sudden death, and finally sometimes some patient may be having the chest pain or dyspnea. So these are the very subset of patient. I don't want to go because it will just mess up with the coronary also. But patient who are complaining on and off sweating, paroxysmal sweating, they will say that एक बैग एक पूरा बॉडी ठंडा हो गया, पसीना आया और वीक लग रहा था. These are the complaints of arrhythmic. VT, VF or paroxysmal AF or paroxysmal AV blocks will present this type of complaints. So it should not be ignored, it should not be turned down, it should be evaluated further. Fainting is the what you call first event or maybe the prior to the sudden cardiac death. So any fainting is happening, which you see from the history point of view, because history is very vital in those things. Any provoking thing is there or not, which is pointing to the what you call vasovagal, it is not there, then always and always it should be explored further because it may be the premonitory sign of sudden cardiac death. So a patient who is dying all of a sudden, either of the dizziness or fainting or palpitation may be one of the complaints which may have been not attended by the doctor or by the patient who has neglected it. And most of the time the patient will be going to the different departments. Most of the time the patient become unconscious, they will immediately reach to the neurologist, they will do CT, MRI, EEG, everything is normal, and then the patient is going home with the labeling that there is no disease. If he is coming to the cardiologist, which type of a cardiologist is dealing, that makes a difference. He will do ECG, echo, even angiography, and he will say everything is fine, go home, you are fine. And if he is very persistent, he reach again to the doctor, somebody will suggest go to the psychiatrist. So depending upon the which doctor you are touching and which doctor you are giving a complaint and how persistent he want to pursue about your complaint, that makes a difference. And why it is important when it is a history of syncope, falls, or loss of consciousness? Because it is not only the patient's safety, it is your safety also. And there comes the net of medico-legal. If the patient is coming and you are not doing the ECG, you are just taking, or you are doing the basic investigation, not giving electrophysiology, wherever you are feeling that the complaints are not being setting in the tone, means the patient's complaints are not fitting in the medical history point. Let us give opportunity to this next level. Means it may be a general cardiologist, he may read to cardiology, and cardiologist may refer to the patient in the neurology and electrophysiology domain. Like that, it should go whenever the complaints of loss of consciousness, fainting is there. Medical fitness. If a person is a pilot or a driver, it will be a big mistake if you are not evaluating properly a syncope, because it will be the persons who are in the flight or on the road will be on the danger. Most of the time, the sudden death may be one of the presentation which may have been missed either due to the palpitation or complaint of fainting, which has not been properly evaluated. And one of the most important thing where I myself also, and even all the electrophysiologists, if they are not having the time, it is very difficult to evaluate a patient with a palpitation as well as syncope, because here the history as well as your ECG are very, very vital to make a diagnosis. If you are not having the mindset, if you are not having the persistent, you will certainly fail. And one important thing, I think the last line is not well visible. What the brain doesn't know, eye doesn't see. So if I am not seeing the Brugada ECG, I'm not having the knowledge that Brugada syndrome is one of the conditions in which the patient will be very young, he will be having a particular ECG which will be coming in a particular situation, or it may be not that all ECG will be abnormal, only one ECG will be having some finding. It should be explored, it should be kept in the differential diagnosis, and later on it has to be labeled by doing some test or sometime doing the ECGs further. Now coming to the arrhythmia. So this was all regarding the presentation of the arrhythmias. Now what are the arrhythmia? If patient is coming arrhythmia, it is very difficult how to approach. So whenever the arrhythmia is, the question comes, we have to diagnose in two ways, whether it is a tachy or it is a brady. So brady means heart rate is going low, and tachy, as we know, the heart rate is going high. So I am starting with tachy because a lot of things has to be discussed, and as you know, high heart rate can be a killer. And very single answer for any tachycardia that we have to make first and foremost is whether it is a narrow or broad, or narrow or wide, whatever you can say. And after that, whatever the permutation, AV association and one-to-one conduction, all those things. But as a GP or as a practitioner, it is a vital question that when you are dealing any tachycardia, the question of you are dealing with a male or female should be clear. Like the same type of singularity and plurality you have to make. This tachycardia is a narrow QRS tachycardia, this tachycardia is a broad case. The question solves because you are going to make the differential only on that subset. Coming first to regarding the narrow and broad, why we want to differentiate. So anything, if it is going through the highway, it will be very fast, what the principle says. And the same thing is applicable for the conduction system. If the conduction starts from SA node and it goes to the AV node followed by His-Purkinje system, it will be always and always narrow, unless the His-Purkinje system is diseased. In that scenario, it may be the QRS may be wide, even though it is going through the AV node. But if it is coming other than the AV node or SA node, AV node and His-Purkinje system, means we can say ventricle, or it is going through the aberrant pathway we call as a bundle of Kent, it will be always broad. So this differentiation makes the things very easy, what we are dealing and how to go further. After that, if the narrow and broad, if you have diagnosed, the next question arises, what to do next. So as I'm just giving the practical tips, I don't want to go what are the diagnoses. So when you are giving, most of the time, if you are getting a regular narrow QRS tachycardia, I think the first reflex will be give adenosine and come out. Or if you are having diltiazem, come out. And it will terminate. If it is not terminating, what are the possibilities? Because these two things will make that easy for you to know what next step you have to take. So anything, when you are giving adenosine, it is terminating. There are only two things which we discuss. We call as a AV nodal reentrant tachycardia and atrioventricular reentrant tachycardia. Means there is a circuit which is connecting upper and lower chamber. It can be in the node, which we call as AV nodal tachycardia. It may be out of node, we call as atrioventricular. Means through the bundle of Kent, there is a conduction is happening. And depending upon the ECG, if the delta wave is there, we call as a WPW. If delta wave is not there, we use the word concealed pathways. Means the pathway is there, but it is not visible in the ECG. And it is dependent on AV node. So the time you give adenosine, it has terminated, and you can see after that there is a gap, means AV block has happened for a transient 4 to 6 seconds, and again the sinus rhythm has generated. And what I was saying, the ECG is very, very classical. So if you want to see, if you are getting this P waves, the inverted P wave which is coming at the end of the QRS, until proved otherwise, it is AV nodal reentrant tachycardia. That can't be possible, and it happens when there is a parallel activation of atrial and ventricles. So P and QRS will be just like having splintered. And there is other tachycardia, what we call as a AV node dependent, which is reentrant tachycardia, in which the pathways, sorry. So conduction is happening to the AV node, and then it is going through the bundle of Kent, which you can see from the lateral part it was going. So that conduction we call as AV node, atrioventricular reentrant tachycardia. So both are dependent on AV node. So you are giving the adenosine, you are blocking the AV node for some time, and you are breaking the VCS circle which was responsible for this reentrant tachycardia, and the patient tachycardia has been terminated, and patient reached to the sinus rhythm. And in the after termination, you can see the delta waves are there. So those delta will give the impression that the patient is having WPW, means both are there. Now coming to the management point, here a lot of time we get a queries from even from the doctor, even from the cardiologist also. Should we go for the RF ablation or not? Should we wait? Or should we go for the medicines only? So answer is, if the patient is symptomatic, means if he's already having palpitation and he has documented ECG in which you are getting, proposal of giving RF ablation is the first treatment that we should give to all the patient. And the reason is only one. If you are giving a drug, you are just preventing the episodes. But if you are giving the RF ablation, it is 99% curable disease. Without, and one of the safest procedure in the cardiology, we can say. Angiography, angioplasty, pacemaker, all are somewhat having risk. But EP study is one of the elective procedure. If the person is very well versed, it is one of the procedure in which you are going to change the life of the patient. He has not to come again for the adenosine or medicine. He has not to come to the doctors, and he has to be totally away from the doctor, means hospital. And this is the thing what you can provide to the patient. And it is the electrophysiologist who loses the most patient, because he ablate and leave the patient that you should enjoy your life. And even in the guidelines also, you can see either it is AVRT, AVNRT, they are having the first class 1 indication. And what we do basically in the EP study, just we are going to keep 3 or 4 catheters. We understand how the pathway is going, how the current is flowing, and accordingly, we are just giving the. So I'm just giving the glimpse how it goes, because I think you may have seen, but usually, so we just puncture from the femoral. We are going to keep 3 catheters. So these 3 catheters we are taking inside. And in the EP system, we are going to just check how the electrical system is going on. So these things, there are some permutation combination we will do to know how the pathways are behaving, and their behavior we just pinpoint. And these are the usually all the angiographic procedure. We use the fluoroscopy to know the catheter position and how they are. So patient is having a tachycardia ongoing, and later on, one of the catheter is having the RF ablation, what you call energy giving capacity, we call as RF ablator. And you can see the heart rate is going, and we just give, we will locate the position by seeing the fluoroscopy and the signal from the ablation. And it is only 30 seconds, which is going to change the life of the patient. So the pathway which was responsible, which is providing the VCS circle, it is going to be totally ablated, or we can say thermal injury has to be done. And after that, we recheck anything more is there, or the same pathway is still left behind. And we may have to repeat again 30 seconds. So this is a total regarding the AVRT and AVNRT. Sometime we are giving adenosine, and after that adenosine you can see there is a lot of pauses has happened and there is only P waves. So this type of response you can get in a patient who are in the atrial flutter or the patient is having atrial tachycardia. We are getting like adenosine, the immediate term, it may not halt. The heart rate will go around 180, 70, and again jump to around 170, 160, what it was. And in that situation, again, we are having the possibility, we have to keep the three possibility, atrial flutter, atrial tachycardia, or atrial fibrillation. Either of the things can be possible. And these are a bit complex. So in this type of situation, RF ablation are done, but these are not the usual RF what I was discussing, the curative type of things. Here we go for the 3D mapping and ablation. So this is bit clinically more, we can say technically more advanced procedures, and that comes with a cost also. So before going in that one, I will touch upon the second question, that is white QRS, means he or she. So again, if you have dealt with the he, next is the she. So white QRS tachycardia, why it happens? So if the ventricles are simultaneously, if ventricle are simultaneously getting activated through the septum, means RBB and LB both are going in the same flow, you will be getting a narrow QRS. But either right bundle or left bundle branch block, what we call, means the conduction is bit weak, it become broad. And that is the thing we call as the aberrancy. Either the one of the bundle, either by the disease or by the conduction is been abnormal, the QRS will become wide. So all the situation of PSVT where the RBB or LBB is diseased or they are having aberrancy, they will again behave as a PSVT with aberrancy and it will be white. But there are some situations where the patient will be having wide QRS other than this SVTs. So it may be drug, class 1C drugs. When you are putting the patient on the TMT, you will see that all of a sudden the patient QRS will become wide because the conduction class 1C or drugs will, and that is way to even judge whether the drug is working or not. Electrolyte imbalances is happening, ischemia is happening, and VT is the one of the commonest reason for wide QRS tachycardia. Whenever wide QRS, whenever we are dealing, the first and foremost question is to be answered, like in the narrow QRS where that patient respond to adenosine or not. Here we are going to see whether it is a regular or irregular, because this makes a decision related to drugs as well as the further treatment and plan of action also. If it is a regular, most of the time the patient will be having some sort of substrate, and this substrate are driver. That's why you are getting a uniform morphology of the QRSs. So if the QRSs are having a what you call one morphology, we call as a monomorphic VT, it is a totally different. But if it is behaving like 3 beats is coming wide and all of a sudden asystole or it is getting fibrillation, we call as a polymorphic. So those things is very, very vital. And this differentiation makes wide QRS tachycardia a very challenge also. So you can see the wide QRS can be like this one also. It may be like this, or it may be like this, which look like to be a sinus, but it is not a sinus, it is a VT, slow VT we call as. So whenever wide QRS is there, the first and foremost question to be addressed is the hemodynamics, followed by monomorphic versus polymorphic. This question has to be answered before moving forward. And here the tussle between the interventional cardiologists and electrophysiologists, where always the interventional cardiologists win. And the reason is any block, any cardiac emergency, they will say the block is there and it is my case, I have to do the angiography, I have to do the angioplasty, otherwise the patient is not going to be saved. And as an electrophysiologist, we have to also come, it is a VT, it is our case, and no doubt we will do the angiography, but probably patient needs a further treatment. It may be device, it may be ablation. So how to decide the patient should go to the interventional cardiologist or it should go through intervention followed by EP? There are some questions which I feel that need to be addressed. So whenever VT is going and you are getting a polymorphic VT versus VT monomorphic, what I say, the question number 2, we have to address. If you are getting a polymorphic VT with the chest pain or loss of unconsciousness, these are the cases where there is some metabolic abnormality which is ongoing, which is the driver, and we have to work on that particular primary entity which is causing that polymorphic VT. While coming in the monomorphic VT, it is usually the ventricle which is having some substrate which is driving, which is providing the vicious circle or re-entry, and that is driving the arrhythmia. And that's why if a patient is having chest pain and he is having polymorphic VT, it is not a case of it is not a case of electrophysiology. It is a case of a hardcore interventional cardiologist. He has to dare. He has to give 2, 3, 4, 5, even 20 shocks, do the CPR, do the angio, put a stent, and come out. Because coronary angioplasty is anti-arrhythmic in that situation. I have faced one case in which we have given 25 shocks to the patient. It was not reverting. We are not having the government approval to do the PTCA. The patient was having triple vessel disease and he was throwing VT like anything. Ultimately, at the night, I have to take a call from the higher authority that patient is having this situation, we can't be able to see. 25 shock, he has beared it. After I took the patient in the cath lab, just did angiography, and there was one vessel which was totally blocked. The time opened, after that there is no need of antiarrhythmic also. We have given cardron, we have given lignocaine, every sort of medicine given, failed. Putting a stent, putting a balloon, that is enough. Just revascularize. So that is the role of interventional cardiologist, or we can say intervention, and that is only for that particular niche case. Polymorphic VT in background of ischemia, it is a stenting, nothing is going to work, don't try it also. So polymorphic VT, the second question is whether it is associated with a prolonged QT versus normal QT. And this is a normal QT which will be most of the time associated either with the channelopathies, what we call as a Brugada syndrome, or we can say long QT, ERS, the malignant repolarization abnormalities. So in that also, and drug-induced and long QT we are already knowing. So whenever polymorphic, it is an emergency, and we have to treat only two things. One is drug which is causing, and sometimes if the patient is having long QT, we have to again put on the drugs. So beta blocker become the drug of choice in those situations, like CPVT and long QTs. And if the patient has any time developed cardiac arrest, or he is having syncope or family history of sudden death, then in that situation we have to give the device, and we will come across what device we have to give to the patient. So in acute broad QRS, cardioversion, if it is a VT, and start the drugs, these drugs are going to prevent the next episode. And definitive treatment will be the ICD and ablations. So how to decide which patient should go for the ICD and which patient should go for the ablations? So this become also again VT, when a story of VT is coming, the next question is whether the heart is normal or whether the heart is having the structural abnormalities. So structurally normal heart, we are saying that patient is having angiographically or echocardiographically totally normal. We are getting everything absolutely normal, but on top the patient is throwing VT. And there are particular type of VT which will happen in a structurally normal heart, that is called fascicular VT and outflow tract VT. So these VTs will be happening in a normal heart. And there are some syndrome like a Brugada, long QT, and CPVT, in which the patient will start throwing the polymorphic VT, and in which we have to go for the EP study RF ablation. It is a fascicular VT, and if it is a channelopathy, we put the AICDs. So these are the defibrillator. And if the patient is having coronary artery disease, hypertrophic cardiomyopathy, or arrhythmogenic right ventricular dysplasia, these are the conditions in which the heart will not be normal. Echo will give all the information that heart is having ejection fraction problem, hypertrophy problem, or there is some right-sided abnormality. In that situation, we have to put the patient on the AICD, followed by, if the patient is developing recurrent VT-VF on drugs, then we have to ablate. Because here we are going to reduce the episodes. So structural heart disease, AICD, and the procedure is almost same like the pacemaker, what we do. So we can see these are the ICD leads, means they are having the coils, and after connecting with the device, this will act as a current of flow. And certainly, sometimes people ask from us, sir, patient is having pacemaker and ICD also, means both the things are there. So let us understand what pacemaker is and what AICD is there. AICD is basically a upgraded version of the pacemaker. Pacemaker is having the function that whenever the heart rate is going low, it will just keep the heart rate at a particular programmed rate. But ICD is having one additional function. We can see this is called bradycardia pacing. Means the heart rate, when it is going low, it will sense and start pacing it. But there are two additional functions which is there in the dual chamber ICDs, means dual chamber implantable cardiac defibrillator. One is called VTVF discharge. So whenever it is detecting a VTVF, it will start giving the therapy, and the therapy will be of three level. Number one, ATPs, it will start chasing the beats. Second is cardioversion, and third is defibrillation. So these functions will be there. So all the ICDs are basically a pacemaker with defibrillation. So this confusion should go off that pacemaker is different and ICD is different. ICD is having all the property of pacemaker with additional features. And again, the procedure, if you can see, the procedure is a very minimally invasive procedure. What we do, we just give a small nick at the just below the collarbone, and after that, like implantation of any procedure, we have to take one port. So through that one port, we are going to take the leads, and the leads will go inside the heart. We will screw it, and finally we come out after connecting with the pulse generator. So the same procedure for pacemaker, ICD, CRTs, all will be having the same type of net. Here, whatever we have taken the axillary vein port, and finally we are entering in the ventricle, and after that, you can see we start screwing it. We have screwed in the heart, and then we will connect with the pulse generator and we will come out. So this is a total 1 to 2 hour procedure, 2 to 3 day hospital stay, and then 3 to 6 month follow-up. And fluoroscopy we will be doing. Coming to the second part, what I have left behind, the EP study in a case of VT. So we call it a 3D mapping and 3D mapping of arrhythmia and ablation, and this is somewhat more technically advanced. Technically advanced because it is not available in most of the center, and the procedure is also having some difficulty because of the technicality what we did. So here we are going to create in rest. Till now what we are doing with the same angiography procedure we are repeating in the patients who are having the what you call conventional EP study. But here we are taking the computer system. You can see here the computer system is there, and there are two systems we call as a NAVEX system, and this is called CARTO system. The difference is one in which we are going to put the current impedance-based mapping, and this is called magnetic mapping. So here we are using the patches outside the heart, means you can see that these are the patches, and these patches will be put in the different location, and this location will start giving the current, and the three X, Y, and Z, these the three-dimensional shape will be acquired by the computer system. So it will give information where my catheter is, and we'll create a virtual heart on the computer system. So after creating the virtual heart, we will be knowing where my catheter is, and then we will be knowing the precision where we have to give the ablation. Not only that, how the current, how the electricity is behaving inside the heart, because our heart is having its own electricity which we know, and that will be flowing from the atrium to ventricle through the particular channels, and when it is going to the ventricle, how it will be behaving. So you can see this. This is one of the patient who has been having ICD, and later on he is having almost 15 shocks. So immediately patient is having chest pain, and he is having a lot of arrhythmia going on. We have detected VT on the device. So we are just what you call using the catheter. So you can see there is a catheter inside. This is like 16 poles, and we are taking all the information how the heart is behaving. I will show you the index. So this is the what we create on the computer system. So in the computer system, we are knowing where the area of culprit area we call as the substrate area is there. So we are just mapping those things, means how the current is flowing, what is the isthmus which is creating the problem, and after that we will just pinpoint, give 1 or 2 ablation in that particular area, we will isolate, and the VT, whatever is going on, which will be going on. And this type of VT we call as a scar VT. The patient who is having heart attacks or who are having myocardial infarction will be having some sort of scars. A scar can't throw anytime VT. It is the living myocardium inside the scar which give the circuit for the VT. And those things will happen time and again, and sometimes they will become medically refractory. So, sorry. So in this patient, we have just, this is what you are seeing, the dot rasgullas. These are the burns which we have given to this patient in the apical area, and after that the VT has been done. So we are having different systems. There is a arrhythmia system. There are 3 systems, but in India we are having only 2 systems. Means one is from CARTO, that is from Johnson & Johnson. So you can see this is the electricity which is flowing. very difficult to understand, but when you will come in the cath lab, how we are going, this is the, what you are seeing, the pencil type thing is the current, how much it is flowing. So it is reducing means this area is having some scar, and we can encircle it. So coming again, how to go ahead with the, what you call, therapies. So structurally normal heart, we are having EP study RF ablation as a treatment. And here again you have to go for the 3D. If the patient is having ischemic cardiomyopathy, means already myocardial infarction, or non-ischemic cardiomyopathy with dilated cardiomyopathy, ARVC, hypertrophic cardiomyopathy, sarcoidosis, or Chagas, again you have to go for the drug. First put the device, try with the drug. If fails, go for the ablation, because ablation is only going to reduce the episodes. And if you are having the Brugada, long QT, short QT, CPVT, it is a drug followed by ICDs, or maybe ICDs followed by drug. Atrial fibrillation is one of the things which is taking next high. Everybody are very much fond of doing ablation, but a word of caution here. Atrial fibrillation ablation, whatever we are doing it is not going to change much in the patient if it is a structurally abnormal heart, because we are going to reduce the frequency. It is not a curative what we are doing in the PSVT and other things. And second, the ablation is more complex. Why it is complex? Because we are not knowing why it is happening. And so far what we are knowing and what we are doing, I will share with you. So till now, we are knowing that one thing which has been discovered in 1990s, or we can say 1998, 99, that one group has given a proposal that probably the pulmonary vein which is lying behind the pulmonary, in the left atrium, they throw APCs, and these APCs fall in the particular repolarization time, and it convert into atrial fibrillation. So we have to prevent the entry of that APCs or the fire from the pulmonary vein, we call as a pulmonary vein isolation. And if you are able to prevent, then the atrial fibrillation will not happen. This is the premises on which the therapy has started, and this has taken for last 2 or 3 decades. It is flourishing like anything. In the US and Europe, this is one of the commonest procedure done, but in our country, it is not the commonest, it is the rarest procedures. And if you want to grab the market, you just say that I do atrial fibrillation, means you are doing a very great job, because it is not a very, productive, but very money earning. So we can ablate in 2 ways. One way is we can burn, and we can freeze. So both the therapies are there. So burn, what we are doing is the same AV, we are giving point by point ablations. And you can see this, whatever the APCs are coming, we just want to isolate. So put a catheter and ablate it. But the risk of procedure, procedural risk are a bit higher than the normal routine. And second, it has become more practice, and it is very easy to do, need less learning curve. That is a cryoablation. One puncture, you go toward the left side of the heart, put a balloon inside the pulmonary vein, just inflate the balloon for 2 to 3 minutes and take out. The vein is isolated. So we are going to keep the heart at minus 60 degree, that pulmonary vein ostium, what we call, and we think, or we are getting the report that pulmonary vein is totally isolated from the left atrium. So this is the treatment for the atrial fibrillation, what we do. And with this, our all tachyarrhythmias is over. Now coming to the bradyarrhythmias. Okay. I think I have to be short. Anyhow, in this, there is nothing more very complex. Here, the bradyarrhythmia, there are 2 things we have to learn. That is whether we are dealing with a SA node or AV node, and if it is the differentiation which may. Thank you. And the treatment is very simple. We call it a pacemakers. Pacemakers are having different variants, either single chamber, dual chamber, or it may be a micra. But basically, pacemaker is an inverter, and implantation procedure, what I discussed earlier, the same. Whatever device we are putting, either pacemaker, ICD, and CRT, all are having the same. After that, patient is discharged. Later on, the patient come in the follow-up. We do but now we are having the remote monitoring. You can do from the home also what is the status, but you can't modify the parameters. That is for the safety point of view. Not this, we are having now the opportunity to send the information by the Bluetooth also. So your mobile will give all the information what your device is doing with your heart and how the heart is behaving with the device. After all the success, whatever we have done, finally we land up with a failure also. And I will say this failure is not a failure. The heart failure is the success what interventional cardio, or what a pediatric cardiologist, what a general cardiologist, or what a general physician do with the heart in doing in the long term. He is protecting the heart. Sometimes the heart pumping will get weakened, and we call as an impairment of heart failure, impairment of the heart function, which in medical terminology is called heart failure. So nothing very big about it. Heart failure, when it comes, everybody just put their hand up. And why it comes to the electrophysiologist, these questions come. So there is one subset of patients in which there is an electrical problem we call as a left bundle branch block, which may be the driver for the heart failure. And the time you correct it, the patient's pumping, or we can say the patient ejection fraction improves also. So this is the electrical area which we start playing. And this type of patient, we give a booster. So we have given inverter, we have ablated, we have freezed. Now we are giving a booster. And this booster we call as a CRT, cardiac resynchronization therapy. There are some subset of patients for which we can advise. And those subsets should be very clear. The patient should have the ejection fraction which should be reduced, less than 35%. The patient should have some bundle branch block, and that has been defined how much the QRS should be. And there should not be any reversible factor. Means the patient should not be having any disease which is reversible. And finally, he should have been given an optimum medical management for a particular time before taking. And this optical medical management, you can see there are the beta blocker, ARNI, MRA, and finally the SGLT2 inhibitors also been added. So it has given a very good management for the heart failure. But if the patient is having left bundle branch block or QRS is getting widening, these are the patients who are going to do well on giving the CRTs. So there are CRTD, means with defibrillator, or CRTP, means only pacing. If the patient is having heart failure and the QRS is narrow, means we have to see the ECG and you are seeing the EF 35 or 25, whatever it is running in the present scenario, and QRS is coming around 110 or it is 80 and 90. These are the patients you are having only two choices to make. Either go for the transplant if patient is young enough, or put the patient in the LVADs. So there are some devices we put. But the difference between these two things is cardiac transplant cost around 15 to 25 lakhs, and LVAD start from 1 crore to 1.5 crores. So that is the difference. And India is the country where the transplant should be given the opportunity because of the road traffic accidents which is happening, and heart get wasted without being used for some proper persons. And LBB, what we have to see, ECG wise, if you know that if you are getting a V6 negative, V6 positive and lead 1 positive, and QRS more than 120, it is fulfilling. And atypical will be having some other features. But important information, any heart failure with reduced ejection fraction will be having around 1/3 of patient will be having LBB. These are the patient in which if you are going to implant, probably the patient ejection fraction, or we can say heart pumping, will get better. But we should be very cautious because this device comes with a cost, and cost comes from 9 to 11 lakhs for the CRTDs. And if you are going for CRTP, it will be 5 to 6 lakhs. And around 30% of patients will not be responding in the indicated cases. So we have to be cautious for selecting. And device point of view, if you want to know the pacemaker, all the steps are same. Only difference is only one point, that here we are taking the coronary sinus, which is between the left atrium and left ventricle. We enter through the CS os, we enter into the one of the branch, and we put a lead. So it is an epicardial lead which is lying in the left ventricle on the left side, and that start resynchronizing. And by that we are able to get the dysynchrony which has been corrected, and after the PG connected. This procedure takes 2 to 3 hours, 4 hours, 5 hours, depending on the CS anatomy. And EF of less than 30%, QRS which is wide, and patient is well tolerated with, has been given a chance. These are the patients who should be given this advice. Here, one more important, CRTP versus CRTD. This is means because cost is an important factor. At least 3 to 4 lakhs difference comes if we are going from CRTP to CRTD, and we should know why we are going for CRTD. So all the patient who is having ejection fraction less than 35% are candidate for CRTD. But if the cost is a factor, you can still give a CRTP. And any complete heart block with mild LV dysfunction or any device in which the ejection fraction is less than 40% or needing more than 40% pacing, they are also the candidate. So this is my last slide. And coming to the heart failure management, what we have discussed, that all the LBB with heart failure are candidate for the CRT, means cardiac resynchronization therapy, which we offer. Narrow QRS we can give if the patient is having ischemic ICDs. And LBB with LBB induced cardiomyopathy, means the patient is having normal myocardium and LBB is responsible for a dysfunction, then you put they are the super responder, means their ejection fraction will get normalized. And structural heart disease, wherever possible with heart failure, give a choice of ICDs. Narrow QRS with severe LV dysfunction, we are having only two choices to make, that is a LVAD or heart transplant. And the QRS more than 150 are the candidate with reduced ejection are the patient on which we should give the CRT. Thank you for your patient listening, and I have already overpassed the time. If any questions are there, I will be happy to answer.
Any
This informative session. Now I request Professor Dr. Birendra Kumar Singh, sir, to felicitate our speaker, Dr. Ashutosh Kumar. Sir. Thank you, sir. I request, sir. I request Dr. Birendra sir, please felicitate Professor Dr. Rajiv Kumar Singh. Sir. Now I request Professor Rajiv Kumar Singh sir to felicitate Dr. Birendra Kumar Singh sir. Thank you so much to our esteemed chairpersons and respectable speakers for their presence. Our next oration of the day is Professor R.A. Shakur inaugural oration of ASPI on the theme of access to affordable medicine and promotion of rational pharmacotherapy, where we will fortunate to gain insight into an inspiring talk delivered by our distinguished orator, Professor Dr. N.R. Vishwas sir. So let's welcome our chairpersons on the stage with a huge round of applause. Professor Dr. Rani Indra Sinha, Professor and Head, Department of Pharmacology, PMCH Patna. Professor Dr. Naresh Kumar, Professor and Head, Department of General Medicine, IGIMS Patna. Professor Dr. Harrier Dikshit sir, Professor and Head, Department of Pharmacology, IGIMS Patna.
That's why to compensate the time, I want to have, I will not comment on anything. I'm hand over, yeah, this mic is being hand over to Naresh Kumar.
I'm reading about our ex-director and Vice Chancellor, Professor N.R. Vishwas sir. He is at present Vice Chancellor at Sri Balaji Vidyapith, and he was former Director and Vice Chancellor at our institute. And he was also former advisor to BP Koirala, representative of Government of India, and was Honorary Professor of Clinical Pharmacology at Nepal, Dharan. And also he was formerly visiting faculty at the College of Medicine, King Faisal University, which is at Saudi Arabia, and he is a part of several national and international assignments, having significant contribution to translational research and indigenous technology development, and he has many achievements in his career, which he has delivered here at IGMS Institute. There are innumerable achievements which we have got under his leadership when he was Director and Vice Chancellor at IGMS Patna. Now I hand over mic to Deep.
सुबह में मैंने कहा था समय से चलें समय के आगे सोच सकते हैं, चल सकते हैं, लेकिन समय से पीछे हम लोग हो गए हैं. इसलिए ब्रीफ में about R.A. Shakur. He was a professor of pharmacology in PMCH. His academic career started with MBBS from Darbhanga Medical College in 1972, did his MD in 1978. He served the Department of Pharmacology and he was there as Professor Emeritus at Patna Medical College. Now I invite Professor N.R. Biswas sir to deliver his oration without wasting time, sir.
ये खाने का बाद सब सो गया. नमस्कार. फिर भी सो गया. वनक्कम. आप ठीक हो गया. वनक्कम इज ए तमिल वर्ड. इसका मीनिंग है नमस्कार. डॉक्टर दीक्षित कोई टेंशन नहीं है. अब हाँ ठीक है. ये अब व्हाट आई टोल्ड यू माय रिक्वेस्ट आपने सुना है. 5:30 बजे था तो अपने प्रिपेयर कर दिया 5 बजे. फिर भी कोई रिलैक्स मतलब रिलैक्स हो जाइए, कोई दिक्कत नहीं है क्योंकि 1 घंटा पीछे चल रहा है. तो इसलिए बीच में जो देखा है मैंने ऑल स्टॉलवर्ड्स दे हैव टू स्पीक. उनको भी कोई परेशान नहीं डालना है. जो भी मेरे को उस टाइम बोलना है मैं 4-5 मिनट अभी बोल देता हूँ ताकि क्योंकि हमारा बॉस आ गया. जब प्रेजेंट है तो वाइस प्रेसिडेंट का क्या जरूरत है. चीफ गेस्ट है इधर, गेस्ट ऑफ ऑनर तो मतलब कोई ज़रूरत नहीं है. प्रेसिडेंट संभाल लेंगे सब कुछ. प्रिसाइसली इन द मॉर्निंग व्हाट आई टोल्ड. चलो कस्टमरी है आप तीनों को ऑन द डैश. प्रोफेसर रानी, नरेश, प्रोफेसर दीक्षित. नरेश को तो मैं ही जुका से ले आया था यह प्रोफेसर बना के फिर ये मेडिसिन के में. इधर नीचे डॉक्टर मैडम है, शर्मा जी है, होता है, विकास है, और भी सब यहाँ है. डॉक्टर बिना है, अरे दिनेश जी आर ऑल्सो. हमारा प्रिंसिपल है. ये तो सब ये इधर भी सब पीछे बैठा है. मैडम 2 मैडम है, सुबह मिला था. हम सबको जान पहचान है. ओके. सो प्रिसाइसली दिस मैन जिसका नाम से ऑरेशन है R.A. शक्कर साहब. जब मैं आया था ही इज़ वेरी डोसाइल पर्सन, एकदम हार्डकोर फार्माकोलॉजिस्ट और अच्छा प्रैक्टिस भी था उनका. ही हैज़ हिज ओन क्लिनिक्स आफ्टर रिटायरमेंट. तो वो बीच बीच में used to come to meet me, and by that time Adil joined here as faculty, not faculty, I think senior resident first. 3 साल senior resident था. तो उस टाइम वो मेरे पास आके बैठता था. सर इसको कुछ हो जाए. मैंने कहा ठीक है, let him do the work properly, get good publication. और by that time हम यहाँ DM भी शुरू किया था. एक शुक्लन को अपॉइंट किया था. तो आई टोल्ड हिम क्लीन वे दैट देखो अगर DM कोई ज्वाइन कर मतलब अप्लाई करेगा तो मुश्किल होगा, अगर नहीं करेगा तो आई कैन एश्योर यू ही विल गेट ए चांस. सो इट्स गुड फॉर हिम दैट टाइम कोई DM अप्लाई नहीं किया था और आदिल को हमने अपॉइंट किया है. स्टिल आई थिंक असिस्टेंट प्रोफेसर. सो दैट इज अबाउट प्रोफेसर R.A. शक्कर. अनफॉर्चुनेटली वेरी अनटाइमली उनको डिमाइज हो गया. I think after 2 years of Adil's joining. About what I tell, हर जगह मतलब यहाँ इतना कुछ हो गया. सब लोग बोलते हैं आपने कैसे किया है. मैंने कहा कैसे किया है तो जब हमने यहाँ एक बार ज्वाइन करने के बाद मेल भेजा है सर को, डॉक्टर Y.K. गुप्ता को. सर मैं तो 9 AM में आता हूँ, 9 PM में घर जाता हूँ. बोलते नहीं, यू वर्क 9 AM to 9 AM. इसका मतलब 9 AM to 9 PM ऑफिस में काम करो, फिर जाके जो काल करना है वो सोचो रात में. तो आई फॉलोड दैट. तब इतना कुछ हो गया. क्या भाई दिनेश, हम ठीक है हैं. फाइनली 8 साल यह काम किया मैंने। पहले 3 साल के लिए आया, फिर 2 साल एक्सटेंशन किया है। फिर नीतीश कुमार बोला नहीं, आपको 1000 बेड नहीं चलेगा, 3000 बेड बनाना है, आपको जो जो चाहिए आपको मिलेगा, आप करो। दिल्ली से परमिशन मिल जाता था, सर हेल्प किया है, तो एट द कॉस्ट ऑफ एम्स आईजीएमएस डेवलप हुआ है, ठीक है, किसी का भलाई हुआ है। तो फाइनली आई लेफ्ट फरवरी 2022, लगभग 1.5 साल हो गया। फिर वहाँ जाके रिटायर होकर फिर आ गया इधर। आई वॉज वर्किंग इन ए ट्रस्ट हॉस्पिटल and then I got chance to work as a vice chancellor to Balaji Vidyapith, so I am working there. What I want to say that अगर कोई भी काम करना है, अगर आपको टारगेट, जैसे मॉर्निंग में वो था टारगेटेड ड्रग डिलीवरी, आपको टारगेट, अगर टारगेट है, फोकस है, परसिस्टेंस है, कंसिस्टेंसी है, तो नथिंग इज इम्पॉसिबल। हार्डल तो आएगा ही, बट हार्डल आएगा, हार्डल के बाद जब आपको वो कंप्लीट होगा काम, तो ज़्यादा आनंद होगा, उसमें सेटिस्फेक्शन ज़्यादा होगा। तो इसलिए हार्डल में डरना नहीं है। 2 टर्म्स यूजुअली आई डोंट लाइक, वो मेरा डिक्शनरी में नहीं है। एक है प्रोक्रास्टिनेशन, मतलब ठीक है आज नहीं तो कल करेंगे, कल तो परसों करेंगे। वो कबीर का जो दोहा है, जो करो सी कल करो आज, जो करो आज जो करो अभी, पल पल में, बताइए। हाँ, तो इसलिए वो होता नहीं है, जो एक बार पीछे पड़ते डिफर पीछे करो, तो जो भी करना है डू इट। एंड सेकेंड थिंग इज कंप्लेसेंसी। एक बार अगर आपको मन में आ गया हमने बहुत कुछ किया है, आगे कुछ नहीं करना है, एनफ, बहुत किया है, तो मतलब चांस कम है। तो इसलिए ऑलवेज यू शुड बी इन टोज, नॉट इन हिल, जैसे ओलंपिक रन में होता है, देन यू कैन डू समथिंग। यही बात मैंने अभी हमारा फाउंडेशन डे था वहाँ बालाजी विद्यापीठ में, बट दे आर वेरी टाइम बाउंड। 4 बजे जाते, क्या बोलता है, 8 बजे जाता है वो, उसका पंच करता है, फिर 4 बजते बजते। मैंने कहा देखो लगभग 500 फैकल्टी है, 2000 नॉन फैकल्टी है, मैंने कहा 2500 लोग हैं, अगर आप लोग 1-1 घंटा एक्स्ट्रा काम करो तो पर डे 25 आवर्स, तो हिसाब लगाइए पर ईयर कितना एक्स्ट्रा काम होगा, तो वी कैन मेक ए चेंज। तो दैट वी हैव टू थिंक ऑफ इट। तो ये इनॉग्रेशन वाला हमने बोल दिया, ओके। सो नाउ आई गो टू माय टॉक हियर टू access to affordable medicines and promotion of rational pharmacotherapy. In the morning also we have discussed a lot about it. The medicine for the all the people, आम जनता के लिए गवर्नमेंट जो प्लान किया जन औषधि स्टोर्स, it's good in many places it is there, but still a lot to do. In some big town like in Delhi there is e-pharmacy also. They also give medicine with a reasonable rate for the common people, and we know that this branded generic drugs price is always higher than their unbranded generic counterparts, because these are two terminology. Even generic has two parts. And as I told, that Jan Aushadhi scheme launched in 2008. Why? To increase access to affordable quality medicine to all the poor people, and to set up pharma stores with government support for cheaper drugs to consumers. So we have also given a person here. What is the name of that man? Kejriwal, Pawan Kejriwal. So he set up a Jan Aushadhi shop here, but precisely it is not successful. Still yet a lot to do. And e-pharmacy also, the problem is that there is no regulation in this, and anybody just phone, no doctors has prescribed, or I don't know, so this prescription validation is not there. So advantage is that due to this proliferation of internet, particularly it happened during corona periods. So you can get the medicine at home, like you get your food by a telephone. So, but it's not available everywhere. Convenience is that they give a lot of discount. So to get good medicine, along with this accessibility, quality is also important. And I have no place to tell about quality because this also a long lecture is needed for that also. But still just in onwards that in the CDSCO they have a lot, lack of manpower. So naturally this pharma company, they make substandard drugs, spurious drugs. There is no methodology to check that. And notification also not properly done. So they give prescribe, and you know a lot of things happen when our drugs go to foreign country, and it gives bad image also. So what to do means there should be a balance between this to provide good quality of medicine with affordable price, whereas pharma industry also to sustain, and for that they have to give good margin also. So this balance to be maintained by the government, and for that this NPPA is there, DPCO is there, different drug price control orders, and this is under Department of Pharmaceutical, Ministry of Chemicals and Fertilizers. They do this work. And in 1995, this DPCO, they have only 74 drugs under their control. Then it increased up to 347 in 23. And you see the difference in these 18 years of these drug price control orders. Increased 74 to 374 drugs. So for poor people or for equity, we need easy accessibility, then quality of the medicine should be good, and strict price control. That is precisely needed. Now, we'll give some statistics here, like Indian total health expenditure, around 3.8% GDP. This is the data of 15-16, and that is around 60.5% of total is out-of-pocket expenditure. Out of this total amount, so people spend 60.5%. And out of this 60.5%, again 43% for medicine. Because our system in India is not fully supported by government, and there is also a federal state, in state to state there is difference. Then central government gives some support, state government also gives some support, but precisely poor patients have to spend from their own pocket. And then in 2004, WHO estimated that 649 million Indians lack regular access to essential medicines. This is the data. And that's why in 2008, this Prime Minister Jan Aushadhi Yojana started to provide quality generic medicines. And the target is again the universal health coverage by all by 2030. And why? To give safe, effective, quality and affordable essential medicine to maximum persons of the patients. Then came this Ministry of Chemicals. They gave the whole charge to BPPI, Bureau of Pharma Public Sector Undertaking of India, to monitor this PMJ. Directly the government does not have any role. They have to control this PMJ. Any non-government organization or government nominated or anybody can operate this Jan Aushadhi store inside any government hospital, any medical college, as I told. Pawan Kejriwal has his shop here. It's flourishing. Medicines originate from manufacturers who follow this World Health Organization's good manufacturing practice guideline. So medicine supply comes from that. And this quality testing drug testing in by NABL, National Accreditation Board for Testing and Calibration Laboratories. They provide the quality checks, but still a lot of demand, manpower demand is there. So not in many places it is being checked. So for the first few years, this program struggled a lot. Even government have given a lot of money. And there was a study with Public Health Foundation of India. They evaluated this scheme. And the finding was that Jan Aushadhi stores overly depend on external supports, means this supply chain was broken, not regular. So there is a shortage of medicine. Even I visited many times in Jan Aushadhi here, and they cannot supply the medicine, and they're telling you we are not getting in time. Problem is that. Then individual state government have their own price. Politics is here. Like say where there is no BJP government, they have their own scheme. They are getting fund for this PMJ, but they are promoting their own other nomenclature. So there are many complex issues are there. In 2005, government rebranded this scheme with more supports along with improved supply chain, and something improved here, causing the number to increase up to 5,200 at present. This is the number of Jan Aushadhi. So up to this what I told, just these are for mainly the PG and others. BPPI should provide more incentive to open Jan Aushadhi stores in rural, less developed area. In rural area, you go to villages, you will not find any. Jan Aushadhi scheme should be flexible and do more beyond providing initial funding for stores. Supply chain can be updated. More centralized system should be in place for better supply. Generic medicines to change public perception by massive campaign. Government also to ensure good quality generic drugs by regular testing, by auditing nationwide. And e-pharmacy is good, but it is still in infancy, and to regulate that also, to curb that mushrooming and flourishing of e-pharmacy to ensure safety. And finally, regulation of this drug access. Because selling medicine from pharmacy only after verifying prescription to ensure drug, and also dispensed ethically by pharmacists who have license or who are degree holder, B.Pharm or D.Pharm at least. Next is the term affordability. As I have already told that out-of-pocket expenditure for medicines, millions of millions, they have to sell their all land, all other property, because first you have to save your life, your teeth and kin, your father, mother, children, and that push millions of people to poverty. Then came this national health accounts. They did some study, and it was found that in 2013, 14, 51, more than 50% cost is only for drugs. By controlling this price of drugs, some improvement happened from 51.67 came down to 43.12%. And you see this difference of roughly 8% or like that cost 25,000 crores. So government saved here. And this data is the starting of drug price control in India. So after that, then government thought, why not do something here? They made a ceiling price, like therapeutic window in a pharmacologist, you know, this minimum effective dose and maximum tolerated dose, and dose should be in between. So they made a upper maximum price called price ceiling price, and minimum price. You cannot sell below this, because naturally then you have to make a substandard drug, spurious drug. You cannot get some profit out of it. So some floor price and selling price. And sellers are prohibited to sell drugs beyond this boundary. You can't. This is Section 3 of the Essential Commodity Act 1955. And then came the DPCO order, market-based criterion. From essentiality base, they found some other criteria, some other formulation. and that reduces more, only 74. And then came this NPCA, National Pharmaceutical Price Authority, that was created. And its function is to see the revision of drug pricing, inclusion or exclusion of drugs from price control. I think Sir is also involved in some, Dr. Gupta sometimes in that committee. And latest one is this DPCO. Maybe Dr. Mehdi is also involved there. I have no latest knowledge. And this latest one is again switched back to essentiality based criteria for selecting which drugs fall under price control. And these order targeted the formulations what the patient actually consume. And this also makes the regulation more direct and in the interest of the consumer. So it is patient centric and patient favoring. And these formulations deemed essential are compiled in the national list of essential medicine. Then came this NLEM. And you know, many of you are involved in this committee for making these drugs, which should be in NLEM. I was there also when I was in Delhi. And this may change from time to time according to the disease pattern, according to the requirements. And of course, this price regulation also changes accordingly. A number of bulk drugs under price control again rise in 347 under this national list of essential medicine 2011. So let us see 347 number which are under control of government. And this is in a bar diagram. 87 less than 150, 95 it came down less than 100, and again in 23 it comes nearly 350. And again there are some drugs which are overlapped in this 87 drug price control order, 95 and 203. So some drugs are common, but this is precisely the figure. Other forms of price regulation within this DPCO, there are scheduled drug and there are non-scheduled drugs also. So scheduled formulation are those that fall under regulation and subject to price control. Non-scheduled formulation are still monitored by government, not under this DPCO. And then when this NPPA created, I told you, they monitors the maximum retail price of all drugs and prevents manufacturers from increasing MRP by more than 10% for non-scheduled formulation from year to year. And that is again flexible. So what is the recommendation till I told about this affordability? There should be more strategic price control on drugs which are used to treat new prevalent disease. And this price control is a double-edged sword, as I told earlier. We should be carefully used, keeping in mind the two objectives. The growth of industry, because unless you encourage them, because industry people, they earn money and then they invest. So in that way, this vicious cycle goes. So if you curtail it, if you prevent that, there will be no innovation and there will be no investment. And simultaneously, you have to see the interest of the consumers. So there is a balance to be maintained here. And second, doctor prescription should focus more on generic medications than branded ones. This is, we are talking long time, but still not done properly. Clinician is sitting here in between. If I ask him, he will tell, no sir, this is not available, generic drug not available, we have to write this. There will be 100 excuses. Branded medicines are more expensive regardless of whether the bulk drug is patented or not. An increase in generic prescriptions not only creates more demand and competition among the generic producers, but saves consumers needless extra spending. And third, quality standards for generic medicine should be maintained for the eventual benefit of consumers. And these are few points to remember, that's why repeatedly I am telling. This is again I tell for the PG. So pharmaceuticals contribute 43.16% to the total of out-of-pocket expenditure on health. 43.16%. You see, if you earn 100 rupees, so 43 rupees you spend for only medicine. Pradhan Mantri Bharatiya Jan Aushadhi Parijojana, that PMBJP scheme aimed at providing cheap, high quality generic medicine, now has at least more than 5,000 stores throughout the India. And these Jan Aushadhi schemes have maximum expansion mainly in the urban districts. So a lot of to do for village level. E-pharmacy only 0.5% of Indian pharmaceutical market. It is very infancy. Between 3 to 4% of the drugs found very substandard or spurious or fake. So in short we call FS. So these FX drugs originate from manufacturing site that may lie outside the state legislative boundary. So बहुत सारा पेज है इसके बीच में. Multiple firms are responsible for notification regarding FS drugs. Price control has been chosen as the policy instrument to keep cost of drugs low in the country. The disease burden of the country has shifted away from communicable to non-communicable disease. So these are mainly 8 or 9 points I enumerated. And the final part of my talk will be the rational pharmacotherapeutics. It's every day the teachers here, they teach to the students, but just to summarize that, few points. You know what is this rational pharmacotherapy, and there are different types also. And that not only cure but prevents also the, or prevents worsening of the symptoms. So how we can promote that? By application of your knowledge, pharmacological information together with the knowledge of the disease for its prevention, mitigation and cure. So use of pharmacological knowledge for better use of patient cure and prevention. And so this correct use, proper dose, proper selection, proper duration, you know all these things. And it can be done in a very comprehensive way. So identify the patient's actual and potential drug related problem, resolve the problem and then prevent also that. Again some data here, worldwide 50% of all medicines are prescribed wrongly. It's very clear. That is the fault of the prescribers, physician, surgeon, whoever. And again 50% of patients fail to take them properly also. That is the fault of the pharmacists. They either don't take properly or the patients also make their mind and they take instead of BD, TD or instead of TD, OD. So these are all. So that's why cure is not proper. And irrational use, you know all these things about this polypharmacy, inappropriate use of antibiotic, overuse of injection, failure of prescribe in accordance of clinical guidance. That is the physician's fault. And self-medication is also. And these are different indicators you give when we are student. We are also given to get data and we publish articles out of it. There are different indicators of World Health Organization. Prescribing indicator, patient care indicator, facility indicator, complementary drug. But these are very essential to get proper drugs prescribing for rational use. And some training is also important for rational use, promoting the rational use of drugs, medicines in the hospital as well as in the community level. There should be drugs and therapeutic committee. It's very essential. All hospitals should have a committee. And a problem-based pharmacotherapy teaching, even to the undergraduate level, you can teach them. Pharmacoeconomy is important. Drug policy issue for developing countries. Then this anatomical therapeutic classification, daily defined dose methodology for medicine consumption. So these are all criteria for rational use of medicines. And again there are few points highlighted that core intervention to promote rational use of medicine, a mandated multidisciplinary national body to coordinate medicines use policies, then make standard treatment guidelines. So time to time we do it and we update it also as to the essential medicine list, drugs and therapeutic committee in district level, in larger hospital, problem-based pharmacotherapy training for UG, continuing in service medical education, supervision, audit and feedback, independent information, not by influence by the pharma companies, agent, public education about medicine, avoidance of perverse financial incentive. Sometimes some company gives some incentive, okay, write our medicine, I will give you some ticket to go some international conference, I will give some car, these, that. So these are called perversive incentives. Appropriate and enforced regulation is very important. And finally, government's funding is also important. In other words, you cannot, this will be failure. So what is the, a few points about what is the role of this committee? Therapeutic committee developing, adopting clinical guidelines for health institution, selecting cost-effective and safe medicine, implementing and evaluating strategies for medicine use, providing ongoing staff education by CME and other thing, controlling access to staff by pharmaceutical industry. You have to curb it to promote their own product, monitoring and taking action to prevent ADR, providing advice about other drug management issues like quality and expenditure, pharmacoeconomics, and then the regulatory measures to support rational use. This registration of medicines, limiting prescription medicines, setting educational standard, licensing health professional, doctor, nurse, licensing of medicine outlet, retail shop, monitoring and regulating medicine promotion to ensure ethical prescription. So these are all to follow. And this is the, I think, final slides, summary slides, that monitoring medicine use and using the collected information to develop, implement and evaluate strategies to change inappropriate medicine use behavior are fundamental to any national program to promote rational use of medicine. Second, a mandated multidisciplinary national body to coordinate all activities and sufficient government funding are critical to success this. Thank you very much for your indulgence and patient listening. Thank you.
In a write-up, but I think it will be more beneficial if I ask or invite my stalwarts here, stalwarts of pharmacology, who are also policy makers, to please add to this or give their valuable comments. So I hand over the mic to them if they would like to add something. Anybody?
Said, a wonderful talk by Dr. Bishwas. And the only thing is that the pharmacologist, the society as it mentions, this academic society of pharmacologists. So you should all be involved in some or other policy making process, help the government in that. So I will comment later, but just because of the time.
Okay, thank you, sir.
An extremely informative session. Now I request Dr. Hitesh Mishra, sir, Additional Professor, Department of Pharmacology, IGIMS Patna, to come over the stage and read the scroll.
Okay, so this is the Professor R. A. Shakur inaugural oration of ASPI there. And regarding our ex-director, Professor N.R. Vishwas. So Professor N.R. Vishwas has an extraordinary journey, a beacon of excellence in the realms of the medical sciences and the pharmacology. His contribution have enriched the medical landscape and left an indelible mark that resonates through the corridors of the healthcare. So while Professor Vishwas, now I am reading the last line because of positive time. So while Professor Vishwas' achievement was to encapsulate fully his remarkable journey, reminds us of the boundless possibilities that await when vision, dedication and innovation converge there. And regarding few words about the Professor R. A. Shakur there. So Professor R. A. Shakur, born in 1950 and has done his MBBS from DMCH Darbhanga and MD Pharmacology from the PMCH there. He served the Department of Pharmacology PMCH for 24 years there and was honored Professor Emeritus of the Department of Pharmacology PMCH by the Governor of Bihar there. And Professor Shakur, as he is no more there, an unwavering source of inspiration, remains an iconic figure in the realm of the pharmacology, and his legacy is resonating, undiminished, whose influence continues to illuminate the path forward there. Thank you.
Request our chairperson to felicitate our orator, Professor Dr. N.R. Vishwas, sir. While a list of accomplishment might be endless, what truly define our guest in this unwavering commitment to excellence and their spirit of innovation. So without further ado, as Sir has to leave due to some urgent work, so we will felicitate him as a guest of honor also. I request Professor Dr. Harya Dikshit Sir kindly felicitate our guest of honor, Professor Dr. N.R. Vishwas Sir. Thank you, sir. I request Professor Dr. N.R. Vishwas sir to felicitate our chairperson, Professor Dr. Indu Sinha ma'am. Ranindra Sinha ma'am. Sitting nahi hai is one. Now I request N.R. Vishwas sir to kindly felicitate our HOD sir, Professor Dr. Harya Dikshit sir. Now I request Professor Dr. Harya Dikshit sir to kindly felicitate our Professor Dr. Naresh Kumar sir. Thank you, sir. Thank you, ma'am. Our next symposium is about reform in postgraduate education in pharmacology. Now I'd like to invite our respectable chairperson to the stage for the next symposium. I'd like to invite Professor Dr. Shantanu Kumar Tripathi, sir, Principal, Netaji Subhash Chandra Medical College and Hospital, Amara, Bihta. Sorry, he is not available. Now I would like to call Professor Dr. Vikas Mehdi, Professor, Department of Pharmacology, PGIMER, Chandigarh. Sir, please come on stage. Professor Dr. Meera Desai, ma'am, Professor and Head, Department of Pharmacology, SL Institute of Medical Sciences, Ahmedabad. Ma'am, please come on stage.
To all, may I invite Dr. Ranjit Guha for the first session on enabling factors for successful implementation of competency-based undergraduate and postgraduate medical curriculum.
Very good afternoon, respected chairpersons. Respected chairpersons. Okay. So, read only.
Institutional Ethics Committee of various medical institutions. He's a regular NMC assessor and coordinator. He attended and organized several state, national, and international conferences, seminars, symposia, workshops. He is a peer reviewer of various scientific journals. He is presented with several award-winning papers. So with this brief introduction, may I request Dr. Guha to please start the session.
Thank you. Really short of time, and we are almost running late by 1 hour, more than 1 hour. So, respected chairpersons and all the galaxy of stalwarts pharmacology sitting in the front rows, and all the delegates and all the students, resident staff, print and electronic media persons. So actually it's my pleasure, honor, and I am really humbled and privileged to stand in front of all of these esteemed erudite pharmacologists of India, where we little bit talk about the medical education part, particularly in the postgraduate competency-based PG curriculum in pharmacology. And actually, I will just introduce the topic as my guiding force, Professor Dinesh Badwal sir is sitting here. So we will be more eager to listen to ma'am, Rege ma'am, next speaker, and Dinesh Badwal sir. So my work is just only to make the path smoother so that they can then move on there. From there, they can take up the things. So now the question is, we all know that competency-based curriculum has been delivered for the undergraduate, that is in 2019, the ball is already been delivered, right? So that is about the UG curriculum, and we know in 2022, actually 20th June 2022, it is notified, and then guidelines for all the competency-based PG curriculum for all broad specialties and super specialties, and it became available in the NFC website on 21st of June 2022, and then gradually all the subjects, broad and super specialties, competency-based curriculum guidelines came. So that for that also, ball is just delivered or just released. But the million-dollar question is that whether are we ready? We are ready means different thumbs up there, because when I have seen, I have visited many colleges, and in this aspect, what I have seen that in many colleges, it is going on quite efficiently. So implemented very successfully in some colleges. But of course, in many colleges, it seems that it is not proper. They are not properly unable to, they are not properly able to tackle it, and for that, whether should I say that it has been implemented properly, or should we say that the work is still in progress? So that's why I think this is one of the important thing, faculty development program, which is one of the most important enabling factor for implementation, successful implementation of both the UG and PG competency-based curriculum. Which can be assessed also. Any new training evaluation we know by the Kirkpatrick's 4 level, we can measure it by the 4 criteria. Now the question is that competency is an observable activity, and it is the habitual and judicious use of all these things. It is not only knowledge, not only skill, but it is communication, knowledge, technical skill, clinical reasoning. So many things are there, emotions, values, and reflection in daily practice. So that is competency. So there is sometimes doubt between this is competency, you see what needs to be done. So driving a car is a competency, suppose, then the who can do it, who can drive it properly, so he is competent driver. And he is doing his, why he is competent? Because he is showing, he or she is showing his competence in that. So that is what he or she does. And in that case, continuity, objective learning outcome and competency. So GC with example, so objective starts with the action verb, we all know. So able to correctly elicit immunization history, that is an objective of an infant, that is an objective. But learning outcome of this objective, if this objective is achieved, then which learning outcome will be there? It is, they will be able to identify the deficiencies in the immunization and all these things, remedial doses. So what competency finally achieved by these? That competent, they will be finally, after achieving these, they will be competent to run a well baby clinic. So competency is a broader thing, and objectives and outcomes are actually sub-competencies that are broken. And then the CBME, the concept is outcome-based approach, learner-centric outcome-based. That is the main two things of the competency-based curriculum, CBME. So it is an approach to the design, implementation, assessment and evaluation of the medical program, both UG and PG. And the 2019 is a very important landmark year, because the change took place since after the 1997. And so CBME, why these changes proposed? Why these changes proposed? Because there is change in the demographic pattern, in the socio-economic context. Means socio-economic change, perceptions, values, so newly emerging disease. So there are huge advancement by leaps and bounds in the field of advancement in science and technology. So that's why these changes were required. And an approach, you can say, this is an approach to prepare physicians for practice that is fundamentally oriented and organized around competencies. Those competencies delivered from an analysis, form an analysis, competencies derived from an analysis of societal and patient. That's most important thing. These are now societal needs and patient needs. That became the first priority. From there only all the competencies has been derived. And it de-emphasizes the time-based, because traditionally is the time-based training, but it is competency-based training. And it de-emphasizes time-based training, and it promises greater accountability, flexibility, and also learner-centeredness. So CBME acts as a driver for improved quality of care, and it is about fulfilling the patient needs. That's why competency based education, we will see that the difference. So mainly characteristics are the learner centric, outcome based, patient centric also. That's why gender sensitive, outcome oriented learning outcomes, and there is a lot of emphasis on this alignment and integration. So these are the highlights of the new UG curriculum, where we can see this is the at the subject wise competencies, sub competencies are there, and some new things are there, like starting from the foundation course, electives, early clinical exposures, revision of training learning formats, then skill acquisition, skill certification, and very important thing is attitude, ethics, communication at compart, and multifaceted assessment. That is very, very important. It is not only a summative assessment, but it is a multifaceted assessment for learning, assessment of learning, and assessment as learning. The three types are here. So this is the highlights. So this is the paradigm shift. You can see the shift is from theory to practice. Main shift from traditional to the CBME, main is from shift is from theory to practice, from teacher centered to student centered, from theory based to scenario based. The case scenarios, because they are real life scenarios. So that's why scenario based, hospital to community based, solo subjects. This is very important, because now this is the time where the departments should not work in silos only. They should break the shackles, and all the departments should integrate together to contribute to the teaching learning methods for the teaching learning of the students for competency. So from solo to teamwork, from solo subjects to integrated learning, and from pieces to complete picture. Otherwise knowledge gaining was piecemeal, skill everything was in piecemeal. Now it is a complete holistic approach. Because why? Because IMJ, that is the Indian competent Indian medical graduate, that is the ultimate aim that all colleges are supposed to beget the in the market, that competent Indian medical graduate who will be having requisite skill, knowledge, skill, attitude, values, and responsiveness. And for this they should perform, they should be able to perform certain role, because they will be able to act as a first or primary contact physician of the community, being globally relevant. So think globally, act locally, and so that they can finally render preventive, promotive, palliative, curative, and holistic services. So for that they have to acquire certain roles. Now I am coming to that. So no piecemeal knowledge can do that. It's complete holistic. So change also, teacher also changed. Role of teacher also changed from person to content transmitter. Teacher initially was content transmitter, but now became a facilitator, mentor, guide. So these are the different roles of the teacher in the competency based medical education. Teacher is a facilitator, guide, mentor, performance, not performance assessor. Please see what is written, performance accessor. Teacher will access the performance and then will do proficiency, all these things of the teacher. But when this has been introduced both in UG level and PG level, particularly, these are the verbatims. I have given some verbatims of the thematic analysis, came out from various studies. So here some told that is a very good initiative, but some told it is a welcome thing, but it is implemented in haste and it change is very drastic. It's very sudden change, implemented in haste. And some said that integration is key to success of CBME. Some told that this is nothing different from the old curriculum. This is just a consortium of new terminologies only, nothing. So this all came out in the thematic analysis, and it is a great stress and harassment to the students and teachers. So these are verbatims derived from the thematic analysis. Anyway, so goal, role, competencies, objectives, assessment. These are the main important thing. What we can see, So this means the goal is there to produce the competent Indian medical graduate, thinking that I will coming to that, and the role C2L2P, they should perform the role. Means these IMJs, how they can act as a primary physician of the community, being globally relevant, having requisites, knowledge, skill, attitude, values, and responsiveness, and rendering preventive, promotive, curative, holistic, and palliative services. So for that, they need to perform certain roles. and that is C2L2P. That means they must be good clinician, communicator, leader, lifelong learner, and professionals. So these things were not taught previously about the management, about the leadership quality, about the values, about the responsiveness, about the attitude, ethics, communication, the soft skills, communication, soft skills. So soft skill was not very much given emphasis on the traditional curriculum. Mostly didactic, their gaining of knowledge was there, but not application of knowledge. It was mostly knowledge gaining, not application. What is important is the hierarchy. If we go across the hierarchical level of the Bloom's taxonomy, so it's not only knowing, not only recalling, but understanding, then application, explaining, and analysis, synthesis, evaluation. So going higher level. So that's why to that's why to achieve the role, they must achieve some competencies which are already given in the 3 volumes in the NMC. And what is not given, done by NMC, left at the discretion of the faculty and students, the committees, that in every college their role is now to break down each competency already given by NMC into sub-competencies or objectives, which must be smart. You know, the objective should be specific, measurable, attainable, realistic or relevant, and time-bound. Smart objective, smart criteria. So that is goal is, suppose the goal is reduction in infant mortality rate, very important thing, that is the goal, national goal. Then what will be the roles? The roles will be good antenatal care, institutional delivery, means this role has to be performed so that only reduction will take place. So for these curative services, feeding, immunity, all these, which competencies the students must achieve? That is, they must be able to provide antenatal care and they must be able to conduct a normal delivery properly. For that, what are the objectives? Objectives may be, because objectives always start, you know, with action verbs. So, enumerate components of antenatal care, take appropriate history and perform physical exam. Everything is starting with an action verb, you can see. That means if we go from below up, the objectives, these first has to be achieved by the students. So class should be taken, the teaching learning methodology to be applied in such that the students, the learners, they achieve these objectives. They will be, at the end of the session, they will be able to enumerate the components of ANC and take appropriate history, perform physical examination, so that they will achieve the competency, that is able to provide the antenatal care and the conduct a normal delivery. Then they will perform this role, they will become a good antenatal care, institutional delivery, and all these will lead to the achieve the final goal, that is reduction in infant mortality rate. So this is actually the traditional, what says CBM. The thing is competency based. If you see, it's starting with the societal need, that is the patient need. That means health needs, health system, which was not in the traditional. It is traditional curriculum, educational objectives, assessment, and whether objectives achieved or not by assessment, mostly summative. But here it is on the societal need, on the patient need, health system. From there only the competencies and the learning outcomes have been derived, and from that only the entire curriculum has been formed. That's why it is called competency-based curriculum, CBC. And
Sir,
the thing is assessment.
The time is up, so
Okay.
if you can wind up,
So,
please. Yeah.
So this is the thing. So I will just show you some, because these things, some challenges, problems, because that is the thing, the medical graduate, these are the problems, lack of attitude. Feels whenever the thing, because I am winding quickly, important thing is, whenever there is a change, always we see there is a resistance from all corners, resistance from the faculty also, knowing fully well that change is the only constant thing. So that's why important is all stakeholders, particularly that very group who are most influential but least interested, to motivate, to sensitize, to convince them also, and then the faculty sensitization, repeated faculty development program, student sensitization, student development program, and all these things, and assessment, more on formative, facilitating learning, feedback, robust feedback mechanism. So these are important things which are enabling factors actually, because there are anticipated challenges only when the curriculum is launched, and the possible solutions at that time only identified, and with that we having a good progress now. I think it will be very good in future. So thank you very much for your patient hearing, because I had to cut short. because of the paucity of time. And I think it is my
Thank you.
pleasure that I could speak in front of you. I got this much of time only to speak in front of such stalwarts.
For all my medical teachers who are involved in undergraduate and postgraduate teaching, they would agree with me that this is more stressful to the teachers rather than the students. And the competency-based medical education has gone a roller coaster ride. Every month there is some circular, there are changes, the regulations, re-regulation, modification, and that has become more stressful to the teachers. So with this we invite the second speaker. May I?
Yeah. May I invite Dr. Nirmala Ragi? I think she doesn't need any introduction, and she is mentor of the mentor, teacher of teachers, and she has been, emeritus professor for Department of Pharmacology, KM Hospital, and also associated with IRA Medical College, Lucknow. So as I said that she is mentoring pan-India in different programs, and definitely, though we are saying about competency, but we are also should look about the skill. How do you evaluate the skill? Okay, thank you very much. Over to ma'am.
Respected chairperson, invited guests, my peers in the audience, and would-be peers also. At the outset, I thank Academic Society of Clinical Pharmacology for inviting me, Dr. Harihar Dikshit, the HOD, Department of Pharmacology, Dr. Lalit Mohan, Dr. Hitesh Sukaland, and the entire team. My topic is postgraduate curriculum, planning for self-directed learning. Those who are teaching undergraduate students in CBME, they definitely know what is meant by self-directed learning. There are sessions, there are faculty development programs, and there are many definitions of self-directed learning. I'm putting the one which I like, that is by no less, a process in which individuals take the initiative with or without the help of others in diagnosing their learning needs, formulating goals, identifying human and material resources for learning, choosing and implementing appropriate learning strategies, and evaluating learning outcomes. Now this self-directed learning, or SDL, is a basic competence of a human being. And almost every student, every individual has an ability for self-directed learning. And you must have also experienced that. What is important is that they possess the ability for critical self-reflection and bring out some transformative life changes. And that gives them the power of critical thinking, problem solving skills, and support of, that supports the lifelong learning. We always say that we want the students, even the undergraduate goal was to make the lifelong learners as a role. And that is a continuous, flexible, accessible learning throughout the life. That is our ultimate aim. And as a pharmacologist, you will agree with me, we do want our postgraduate students to possess this role. This is a very, very important attributes of a pharmacologist. So in my presentation, I've just divided into three parts. One is the benefits, the challenges of SDL, and the strategies for implementation at postgraduate curriculum. As mentioned in our revised postgraduate curriculum, which has come as CBME, the goal is to create pharmacologists, or for that matter, any specialists, who would provide high-quality education, healthcare, and advance the course of science through research and training. And then they have defined the goals under individual subjects, and for us it is acquisition of knowledge, skills, teaching and training, research, as well as professionalism, communication skills, etc. And you will agree with me that the pharmacology is a very dynamic, ever-evolving discipline, and whatever we have learned in postgraduate level will not help us in the future life, because there is a constant emergence of new drugs, technologies, regulatory requirements, and therefore that self-directed learning is very, very important. And what if we have learned that, and I will tell you, though I have mentioned as an ability why we have to learn it, that will come later. but it will empower our postgraduates to stay at the forefront of the pharmacological knowledge which is evolving. It will enhance their ability to critically analyze the information, which is very important, and to make the decisions based on that. They have to synthesize diverse sources, and they have to apply their knowledge to that novel challenges. And that will deepen when they are doing it, there automatically there will be deepening of their understanding of pharmacological principles. So they will increase their capability to contribute significantly by research or in their practice. But there are challenges. First thing is whatever the pharmacology teaching going on currently, it is mainly restricted. Means we say that, okay, the person has entered the postgraduate department, and now he has to learn on its own. He has to see, he has to observe it very keenly, what his teachers are doing. He has to attend the conferences. He has to deliver the postgraduate seminar, journal club, and the thesis activities. And through that, he will learn. Ultimately, whatever is there on the earth as related to pharmacology, the student should be able to know. That is our usual saying. But actually, the students find it very, very difficult in sourcing the reliable information, and especially in today's era where there is overwhelming, the knowledge explosion is, the doubling time of knowledge is few years, not even few years, in less than 1 year. And there is a maintaining motivation is very demanding in this field. So especially if our student is accustomed to the passive learning as it goes on in the undergraduate level, means not that our CBME course has started, but the first batch has entered the 4th year so far. So it is mainly the passive learning methods. So to struggle with that, and then who suffers the most? Usually the lower achievers, they suffer the most. So it becomes that planning of these HDL activities becomes a responsibility of the teachers rather than leaving it entirely to our postgraduate students. We need to nurture, and why I'm saying that? Because though I said that it is a human, it is a competence which is common for the human, willingness may not be there, and willingness to share the responsibility of as a learner may not be there with our students. So we have to nurture that among the students, and we have to have that learning partnership with the students. So active approach is needed by the postgraduate teachers, and lot of hand-holding is required, at least in the earlier period of time. So I will consider this planning of SDL under the 3 considerations one should give: students, what topic and task, and lastly the methods. So first, as I told you, our students' readiness for self-directed learning has to be assessed. There is a scale which one can use to find the self-directed learning readiness. It is a Likert scale. You get some objective data, but this is not a very time-tested scale. It has been used mainly for the nursing. It depends again solely on that teacher to judge. But usually in SDL, the student moves, there is a progress from dependent to interested to involved to independent. And therefore, we have to have the dialogue with our students to find out what is their stage, whether they are dependent totally as they have come out from the undergraduate students, or they are interested, involved, or they are self-directed. And as the students mature from the entry level to the 3rd year level, then they slowly, based on their previous learning experiences, they develop the confidence also, and they start assuming their responsibilities more and more. And that must be, you must have watched this. So the basic thing is one has to match the level of self-directed learning required to the learner readiness. That is the first principle. Secondly, the teacher has to progress that it is a teacher-directed learning to the learner-directed learning over a period of time. And thus, the teacher responsibility may be more at the entry level, but slowly they may have to demonstrate it. They have to be a role model for the student. But at certain time, they can say that, okay, we can do it together. they pass on that you people can do it together, the group of postgraduate students, and then independently you can do it alone. So the success of this model depends on slowly, gradually releasing the hand which you have held at the first time. And therefore, through these stages, our role also differs. Maybe in the initial stage, it is very authoritative, but later on, it may be like a motivator at a second stage, facilitator. You involve them in the goal setting, involve them in the learning strategies. Then you become a facilitator, that the discussions are facilitated by the students and you are there to participating it almost as an equal. And later on, maybe as a consultant. So that gradual change should be there. The next thing is one of the principles is that you have to support the subject matter knowledge. If you tell that, okay, I'm taking something and then you have to learn the self-directed learning, that doesn't happen. Both the things, whatever their content for or the syllabus is there for the postgraduate study, that and self-directed learning has to go hand in hand. So one has to plan that way and have the learners practice the self-directed learning in the context of learning styles. Related to the topics, you have to select. There are 40 major topics, and our syllabus, I don't know how many of you have seen it, but it is a very good syllabus for the postgraduate student. There are 40 topics have been listed over there. Though it is not mentioned, I feel that they must be the indicative topic because new things can come in. You have to select that topic, which topic you will take at earlier stage and which topic at a later stage, and you have to change it. And you have to judge the interest of the student in the topic also. Not everyone will be interested in all the topic. So see in which they are interested, develop the interest in them, and then go ahead. And usually the real life scenarios will help it. And that's why there is a case-based learning that has been introduced in our postgraduate syllabus. Methods, our students come from diverse backgrounds, they have varying capabilities, and therefore there can't be no one-size-fits-all type of thing existing over here. But you can select based on the individual skills which are required for the self-directed learning, or you can use the SDL model. So this is the knowledge 6-step process which can be kept in mind while designing any planning. One is the supportive learning environment, then identifying their needs, providing them the diverse resources, and executing learning activities. So you have to monitor that, evaluate their progress, give feedback, and then identify their future needs. So related to the individual skills, you tell them what is a need for identification, goal setting that can come through the discussion, brainstorming, giving them certain tasks. See how they manage that particular task. Select the learning strategies you want to use and monitor their self-progress and allow them to reflect. That is the one important thing we have to teach our postgraduate students also. Maybe the undergraduate, the first CBME batch which will come to us, they may be good in reflecting, but not the current postgraduate students. And we have to give the feedback. Now, as I mentioned, that has to be linked with the exploration of the knowledge, the content part competency as well, communication and group dynamics. And why I'm saying group dynamics? Because it is always a collaborative learning, helps them to learn more than the individual learning. So a cycle may be established for the self-directed learning. You make them assess the task, what are their strengths and weaknesses, have a dialogue. Again and again, I will say the same thing. There has to be a communication with your students. Help them to plan. Let them plan and then you supervise it. You monitor that, apply your strategies, and allow them to reflect and give your feedback. This is one model. Dr. Badial has had a paper in 2021. But that is for the undergraduate. There is no harm in using that for the postgraduate studies as well, because it is an excellent one based on the principles of SDL. So you can have this model having the two different sessions, allowing them to develop their learning goals, then asking them to go and do some search, and then having a further discussion and opportunities. This is another model which I like personally. It doesn't tell you how to do it, but it tells you what one has to keep in mind. One, the learning situations. And these learning situations depends on the opportunity, the support and the collaboration. So as a teacher, we have to find out the opportunities where the students can go, whether they are going to go for the ward rounds or they are going to get posted in the different wards. We have to see that what they will be doing. Otherwise, they will be used in those different district hospitals and different wards as a intern, that you do this, you do that. No, as a pharmacologist, what they are supposed to do, we have to develop the list of objectives and we have to talk with a clinician and see to that whenever they are working over there, they are achieving those objectives. The second, it depends on the component of learning. So what is their content skill? Think about the topics which are there, what they are supposed to do as per our syllabus, and what are the SDL skills they are learning through that particular activity and their willingness. So, and the third thing is the students' attribute, whether they are motivational, which context, and what are their cognitive level. So learning, as I already told you, that learning in collaboration is always best. Find out the opportunity, have the group discussion, and those methods have been mentioned. Online forums, discussion group, and student engagement. All these, some of the traditional methods have been there mentioned in this curriculum, like lectures, seminars, symposium, laboratory work, bedside clinics. But what is fascinating is the interdepartmental colloquium, the rotational postings, not only in the institution, but outside at the district hospital as well, but our presence has to be there. And then the guided, I will finish, guided reading, case-based learning, projects, etc.
We'll take the question at the last, after Dr. Badial. So I request you to join us. So now I invite Dr. Dinesh Badial, and he has been contributing in medical education, especially teachers training program. So currently he is a professor and head Department of Pharmacology, CMC Ludhiana, and he is also holding a post of Vice Principal Medical Education of CMC Ludhiana. So along with that, he is professor and convener of medical education. So he is also program director for FEMER Regional Institute. So he has been contributing, as I said, that he has a number of numerous publications in the national and international level. So in the interest of time, so I request Dr. Dinesh to make a presentation and stick to the...
Thank you, Dr. Vikas, for the nice word. The chairpersons and all the dignitaries and the organizers for having this unique, I will say, organization from within the institutions which is taking together all the pharmacologists. As we talk about formative assessment, Dr. Ranjit and Ma'am Righe has already highlighted that how we're moving to the CBME in the post-graduation. All of you are aware of that, how these things have jumped into from 2018 onward. School education, 10th till post-graduation, all are changing to CBME or outcome in the country. So these changes are in alignment with all the educational changes happening in the country. So this is not in isolation. Postgraduate curriculum which has come is applicable from 2022 batch. It means we are in the middle of those students are already with us and we are talking about their formative assessment. Although other institutions were already doing, most of them were doing earlier about formative assessment, but there was no standard process how to do formative assessment. And simultaneously there have been changes in the MBBS curriculum like this. The formative assessment statement which you see here, that what it should be: longitudinal, continuity, should assess knowledge, patient care, procedural, academic health, interpersonal skills, professionalism. So many things are there. What has happened, the same changes happened in the MBBS, and this year for the new curriculum, 5th batch is coming. And you can concise teachers have been trained for formative assessment. We have first batch of MD already with us, second batch of the CBM curriculum is coming, and 5th batch of MBBS. So we had some experience in the teachers, in the MBBS who are already teaching that this is formative assessment. Now a structured format has been introduced, which we call as what we use for assessment for learning, AFL. Otherwise our major part is assessment of learning. So when we talk of formative assessment, it is assessment for learning. So it means whatever the opportunities we have in those 3 years for assessing the students, we use those for learning too. How we convert them into learning, that is a challenge, but that is the major change which is happening. So now you will see there is a format for formative assessment in all MD courses, DMR also MCH. And this has been made standardized across all the subjects. So it is not that you will find it different in MD medicine or MD pharmacology. So it has been done in that way, that assessment is continuous, similar. Formative assessment now, if you see why it has been changed and added in a standard way, so that it becomes unbiased, continuous, transparent, uses a mix of validated methods. Many universities have already devised a lot of their assessment systems. They have created new sample papers because titles have changed now. And more emphasis is on improving the performance and providing the remedial support. It is written in writing, you have to write how you will be providing that support. As I told you, format is also there. So there's a role of multi-teacher involvement in the formative assessment. It means you will be not be talking about, okay, this is my student or I am the guide. It's a multi-teacher assessment, which improves validity and reliability of the assessment. And methods which are used are fairly consistent because they are standardized across the curriculum. But it is important to remember that PG training has many opportunities, and we need to train our faculty in providing feedback to PG students, following the principles of good feedback, giving and as well as receiving. Many times we have seen their sessions on giving feedback, but on receiving feedback is equally important. These are the three basic principles when we talk of formative assessment in any course, including the PG course. Alert the student about the present position, which many of us do and have been doing in the earlier curriculum too. Identify the areas of improvement, that is also like very many places it is highlighted. What has been lacking is providing help to fill those gaps. So it means here teachers need to chip in to provide that help. You have identified student has issues, but how you help the teachers. So on all these principles, there has to be a consensus between teachers and the students, and they should agree to work together on those components. So when we were talking about and working on some of the postgraduate curricula over the years, okay, we had many interactions with stakeholders, what is needed actually, that included students too. And we are also looking up, they were thinking about blueprint the contents, so we are sure what is expected from us. Okay. So both the parties know about that, so that feedback becomes specific. And even the levels, which type of, even the knowledge level, which is the level expected for what topic, if that we can do that. So the new curriculum from 22, you see there are 5 goals now, and these are very clearly defined. It means we will be assessing all the students in these 5 goals and also providing formative feedback. And each of these goals are achieved by competencies now. So you will see statements like competencies now, which can be predominant in cognitive domains, psychomotor or affective domains. So when we assess these competencies, we need to observe. It means we have many opportunities in the formative assessment. So for achieving these competencies, feedback has to be internalized. How? In various postings, because they have dedicated postings now, blueprinting, small groups, okay, lot of demonstration which you are doing for the post graduation, because many places they are not doing actual experiments. OSCE, logbooks, simulations, how you can use formative assessment. Dr. Rekti highlighted some methods. I'm adding more onto that. Which assessment methods are available? OSCE is objective structured practical examinations. But since now NMC says all subjects are clinical, and we are not using that distinctions. Our phases are labeled as phase 1, 2, 3, 4. So as such, all we assume OSPE, we should use word OSCE, objective structured clinical examinations, even in the pharmacology. So a lot of other methods are there. Let's see a few examples. For example, curriculum says for the practical exercise, you have long exercises and short. So when you are preparing them for these exercises, okay, the group of postgraduates is still small in pharmacology. You are not getting 50 per year like some of the other subjects. You can have a dedicated feedback provided to them. Usually we have sufficient time when we are with the postgraduates. So that is the need of the hour. Now look at the many opportunities here. The postings, dedicated postings. In each of the postings after they finish, since other people are also getting trained, other subjects are also getting trained for reflections, feedback, we can provide so much opportunities for assessment and for learning, which is a part of formative assessment, each of these postings. And logbook pattern which is given for UG and PG already by the NMC, that is available. And you will see in this logbook pattern, there is a, you have to find out whether they have achieved the competency or not. Then you will see, you will mark them, whether they have achieved competency exceeds or below. Similarly, what feedback was given, when it was given. That is the important part of that. So it means you need to mention this in the logbook or the portfolios, whatever you are maintaining. And if you see now reflection writing already a part for the undergraduate. Postgraduates are already learning because they are also given a teaching experience certificate. So reflection writing you must include in reflections. That is an important part of formative assessment in cognitive as well as skill area, both components which are there. So quarterly assessment formats you can make or your university can take initiative. Now because regulation says you should have a marks for a formative assessment. Okay, which will be deciding whether they are appearing for the university exam or not. So make it formal. Technically, all those components should be included. You can mark them, you can grade them accordingly. And remember that feedback is very, very important part of this. So that has to be given. If you are doing quarterly assessment, you need to talk to them. What are the areas? Identify it together and then provide remedial measures. Work on that and see whether these remedial measures are working on that. Ma'am told about the SDL. I'm not going to details. Case-based learnings, reflections. All these sessions have a debriefing sessions, which is a place for giving a lot of feedback to these students. Small group, let them take the initiative. You sit out of the group and observe them and later on see whether you need a group feedback or individual feedback. Okay, so that is a part of formative assessment. Other opportunities are a lot of communication skills are there, ethical components which we keep on talking to the students, ask Viva questions. During your training, you need to find out, identify the areas which are lacking in that. So here also when you design these sessions, role plays, remember that feedback must be included. Prescription writing, we talk so much about that. In the oration you have seen, Sir has talked about how we do the rational pharmacotherapy, and these things are available now. Prescribing skills courses, assessment. Okay, these can be used and students can be provided feedback on that. Informed consent is a major part of MD pharmacology everywhere. So when they are administered, sit down there, observe them, find out the issues, and then provide a formative assessment. Remember that so many types of assessments are entirely in your hand, which you can do. Skill labs have entered in a big way. So use them for the postgraduate. It's a mandatory now. So here also, all the debriefing sessions which happen here after the procedure is over. Okay, so you have a maximum time is in the debriefing, which includes reflections as well as feedback. So this is important part of formative assessment in all postgraduate training. So follow this type of simple principles, briefing, running the scenario, actual scenario, which is a small part. Remember, don't go too much into that. Get fascinated by those dummies and all. Where the main learning happens in the debriefing, which happens for 30-40 minutes, where scenario has already happened. Formative feedback. So that is a part of that. Remember, in all this new curriculum, what we are doing, new competency based curriculum, we are providing them this help, which happens in the formative. Hand holding or something, wherever you think the way these days or this generation responds, those ways you need to use. Even online things, if they like that. So that type of opportunities for the skills gaining we need to do. Lot of models like OPC model, poisoning model, lot of other treatment models you can simulate and then have sessions on that. Good discussion followed by feedback. That is needed. These things are doable, feasible. Most of the many colleges have developed the modules. You can publish them, share them. So we don't reinvent the wheel, start using each other's modules. So log of performance to be mentioned so that they become competent. Based on your feedback, if they are doing good, give them feedback to go to excellent level. It is not that only students who are not doing, we have to involve in formative assessment. All students, they can actually reach the mastery level. So remember, feedback is needed for that. So this is suggested pattern that independently observed, demonstrated. These patterns you can mark based on what they are doing, provide feedback, then certify those skills. This is important so that they know they have to achieve somewhere, they have to be competent in that. OSCE or OSPI, many things are already described. Now you use the format which is given for formative assessment associated with these stations which you will use for their assessment. There also it's a lot of opportunities. It can tell you if students are not performing at one stage, station, whether it's a problem with the station or with the teaching learning method, or even sometimes with the assessment. So this will improve the formative assessment, many component of the curriculum. But remember, these things are to be done now in the MD pharmacology, where a lot of formative feedback can be given at various stations, which you can simulate or use hybrid models. All these components, if you see here, participation, ability to work, feedback given, in the checklist you can include that. There can be a learning checklist during the formative assessment, and there can be an assessment checklist during the examinations. It will help your purpose of formative assessment. A lot of people say formative assessment is limited to internal exams. It is not so true. If you look at the new titles of the new papers in pharmacology, the first exam will which will happen for 2022 batch, you will see you need to prepare your students for that. It means internal examinations also you can use a system like that. And if they are not performing well, give them a feedback. Even sometimes if they don't do well in the university exams, we provide them feedback. Okay, so if they have not cleared one of the component, we know theory or practical, we do give a feedback. So there's no boundaries right now for the feedback which can be provided here also. So formative and summative is more like the time period which is at the end and which is continuous. Those things are taken. In nutshell, I will say that formative assessment in PG training, multiple formative assessment opportunities are available. You need to use multiple methods, multiple teachers. Remember that technically and legally, these days, if the assessment formative is by one teacher, it fails in the court. It has to be multi-teacher, and the challenge right now is to modify that attitudinal approach toward PG formative assessment. We should not say when we were postgraduates, nobody provided us the feedback. So we need to change that component which is there and use what is given, because documentation of the formative assessment presently is an essential document these days. Otherwise, so many problems and court cases come up at that level. So documentation is very important of formative feedback, which has to be multi-teacher. Thank you so much.
When we studied pharmacology, I was not knowing what is a food law. I have been titled as a nutritional pharmacologist. When first speaker has mentioned very clearly that the pharmacology should have a different component which is required for the India. How will you bring it? How will you bring that practical subject? Please think of it, madam. Today we have a lack of human resources. I am just giving you one example, but I cannot give you further details about it because I will give it in a coded language. We are screening lot of food additives, drug additives. Indian data is not available. Which additive to be banned? Who should answer?
In our curriculum, even in the textbooks, standard textbooks, at the most, some discussion is there of excipients, additives at the time of formulation when we teach the very first class of clinical pharmacy. But later on, whatever formulations are introduced into the market, a drug which is already approved but is now approved with the different formulation, the excipients, the additives, these are not given the importance. It is mainly the main molecule. So definitely that there is a lacunae, and especially the department, the teachers can definitely take this up. All my speakers, they have really shared the wonderful experience. They are the experts in medical education. And what I have experienced, even before this competency was introduced in 2019, if a student, a postgraduate student, is involved in the day-to-day activity of the department, whether the department is doing undergraduate teaching, is taking up some research project, doing pharmacovigilance, ADR monitoring, the students must be involved. If the student is involved in the day-to-day activity, in the teaching, taking tutorials, demonstration, framing MCQs, he's going to make mistakes. But that is a learning. If the department is organizing any kind of workshops, training program, the student will learn everything. Yes, out of 10 students, you may find 1 or 2 students who doesn't have that attitude. Now, to change the attitude, this especially the structured assessment that he will be assessed in that particular area. That will help. But yes, the time will tell whether this competency based, whether it is really making a difference, as most of us feel. Because the way it is introduced and the way it keeps on changing, ideally, any change which is made by the policy makers, what is required is we need to give 5 years for that change. See the impact and then change further. Or you introduce that change in certain states, not all over India. And then you assess it and find out the limitations. The ground realities are very different. It's very easy to frame. Yes, we can make it. But then the ground realities of government hospitals, private hospitals, they are extremely different. Their approach toward the teaching, their goal, the objective of the organization is very, very different. You cannot compare the central government organization, the government organization, and the private, because I have now worked in all these institutes. It is extremely difficult. And the whole load comes to either to the dean or MU coordinator. Now he is responsible for everything, to catch hold of the clinicians, get it done. Right? Now in this whole chakkar, we are forgetting student. What is happening with the student? We are taking the classes, we are teaching, everything we are doing. But whether this is really making a difference, we have no data. As one point which Dr. Bhota raised.
To felicitate our distinguished speaker, I request Professor Dr. Meera Desai ma'am to felicitate our speaker, Professor Dr. Ranjit Goa sir. Again, I request Professor Dr. Meera Desai ma'am to felicitate our speaker, Professor Dr. Nirmala Regi ma'am. Now I request Professor Dr. Vikas Mehdi sir to felicitate our speaker, Professor Dr. Dinesh Vadial sir. Now I request Professor Dr. Meera Desai ma'am to felicitate Professor Dr. Vikas Mehdi sir. Now I request Professor Dr. Vikas Mehdi sir to kindly felicitate our chairperson, Professor Dr. Meera Desai ma'am. Thank you so much to our esteemed chairpersons and respectable speaker for their presence. Thank you. Our next symposium is about a clinical pharmacology. On the stage, Professor Dr. Devashish Ota, Professor and Head, Department of Pharmacology, AIIMS, Bhubaneswar. Please come on the stage, sir. Professor Dr. S.M. Nasir, Professor, Department of Pharmacology, Calcutta National Medical College, Kolkata. Please come on the stage, sir. I request our respectable chairpersons to commence the session.
Esteemed guest, my director, Professor Y.K. Gupta, and session clinical pharmacology, and there are eminent people in the audience. My director, present director, Dr. Vishwas, Dr. Y.K. Gupta, my friends, my former student and present colleague Anand, and so many faces, known and semi-known faces. So welcome to this session. This presenter is Subhadev Sinha. We had a very good link with him, and
Sir, not needed.
please.
Not needed.
Okay. we can carry on directly. He doesn't require an introduction. He's a very well-known face all around India, so I will not introduce him. So he's Dr. Sinha, and you start your
So I heard about CBME curriculum industry exposure. So by being part, also being part of IGIMS and KMC as an adjunct, I am getting an academic exposure myself. So it's a reverse on my part, and attending in front of luminaries like Professor Y.K. Gupta, Madam Rege, who have been my teacher as well in my MBBS. We didn't have CBME curriculum, but we still managed to get somewhere. So my exposure is entirely industry and very little of academics. I'm trying my best to explain. To my teachers and my seniors, please don't consider this as a viva. I'm trying my best to explain. So phase 1 clinical trials, which is has picked up in the sometime long time back. I'm speaking in terms of industry. We had Dr. Reddy's, who had for the first discovery of DRF compounds, and then it fizzled off. There was a lull in between, and now in last 10 years, I would say 5 years, a lot of companies, including Wokhard, Hetero, and many other companies have been part of the developing new chemical entities, especially in India. And in fact, Dr. Debashis is on the other side grilling me in the SECs sometimes, many times, most of the times. And that is also a wonderful experience to get. Coming to the, this is a known slide that that drugs go through, and any IND goes through phase 1, phase 2, and phase 3, but we are sticking to the phase 1s. The ultimate goal for any phase 1 study is any drug development is right drug, right patient, right dose, and right time. Few terminologies before we begin that what is investigational medicinal products. People who take part in the clinical trials are called subjects. Phase 1 clinical trials do not have any therapeutic benefit to the patients, to the subjects, and therefore are non-therapeutic trials most of the time. Premises where trials are done are phase 1 units, are simply units, and it is part of the human pharmacology discipline. This is phase 1 definition, pharmacokinetics and dynamics. But the important thing is the first step when the potential new medicine goes from laboratory to human beings. It's a gateway between scientific research and clinical practice. It gives a lot of insights and a lot of data which comes out of phase 1 trials get into the prescribing information. So you have chemical entities, biotechnology products, cell therapy, gene therapy, etc. All these depending on the source, they can become different investigational medicinal products. In fact, I forgot to tell my first NC experience and IND committee experience was with Professor Y.K. Gupta. We had to go back and see what we had done mistakes, and although we are not in academics, by these interactions we have learned from in the industry how to better develop a molecule. So we were deficient in some places. We improved by his guidance. So coming to this again, high risk investigational medicinal products. These are high risk because they cause disturbance of vital body systems. There are no prior experience on these mechanism of action, so completely new mechanism of action. High potency such as bivalent antibodies, cell-associated targets. Species specificity, making preclinical risk assessment difficult or impossible. And targets where biological amplification might happen in vivo. So these are high risk. I am stating that because there will be a mention of that. I will not explain the entire preclinical assessment, but any IND has to go through the battery of preclinical studies, including single dose toxicity, repeat dose toxicity, dose ranging, safety, pharmacology, and the works. But the repeat dose toxicity studies are the most important because these studies decide what we call the no observed adverse effect levels, and which decides the human equivalent dose. So human equivalent dose the dose which is extrapolated from animal studies. There are two approaches. One of them is the no observed adverse effect level approach. So where the various the repeat dose toxicity studies are conducted in multiple animal species, and selection of the most appropriate animal species is done, and and then human equivalent dose is calculated based on the formula of appropriate the species NOEL divided by body surface area correction factor. Then we apply a safety factor, because after to determine the maximum recommended safe dose for human beings. So there's another approach, the minimum anticipated biological effect level, done in case of high risk IMPs. I just mentioned what was high risk IMPs. They start with lowest dose even if there is a different MRSD calculation done. Now this is a slide from the FDA guideline which states the various body surface area correction factors. So here you can see the mouse, the dog and the monkey, which is the most commonly used. And whether if you divide in case of mouse by 12.3, if you multiply by 0.08 in, and so on and so forth. The most appropriate species. Most appropriate species is the most sensitive species, the species in which the lowest human equivalent dose can be identified. But that default cannot be done in case there are differences in ADME between the species, and the class experience may indicate that particular animal model may have may be more predictive for human toxicity. So, and there are also in case of biological products where certain animal species may not have certain receptors or epitopes. There is also class experience where certain class where has shown that animal model is more appropriate for. So the entire class has shown. So you need to only follow that the HAD calculated from that class. Although there may be a different HAD values in other. Now the application of safety factor. Now the default safety factor is 10. The safety factor is 10 means whatever HED is calculated, it is divided by 10, and then that dose is taken. For example, if the value is calculated as 25 or 2, so then you have to divide it by 10. So 2.5 is the one dose where it should start. The safety factor may be increased in case by more than 10 in case there is a steep dose response curve where there could be significant toxicity on the steep dose. Severe toxicities might be seen in the preclinical toxicity, especially organ damages. Non-monitorable toxicity such as histopathological changes, variable bioavailability can be seen in between animal species. There could be irreversible toxicity in certain studies. In those cases, you have to increase safety factor. Further, unexplained mortality, large variability in plasma drug levels in the animal pharmacokinetic studies. If there is non-linear pharmacokinetics, if there are completely new class of agents, novel therapeutic targets, and so inadequate dose response data. In therapeutic biologics, animal models have very limited utility. So you might have to increase the safety factor and lower the dose for the starting. Decreasing the safety factor, yes, it is very rare, but it might happen in case it's the same class of product with the same route of administration, same schedule, same, everything is the same, everything is known about the same class, it's just a class extension IND. In that case, you may actually decrease the safety factor. And if the NOEL has been calculated from long duration toxicity studies such as 180-day toxicity instead of 28-day, so in that case the exposure is already for a long duration, therefore the safety factor can be reduced. So general principle of first in human studies rather, done in small number of healthy volunteers and slowly increase the dose to safe tolerated dose, and then it is performed by clinical pharmacologists. The center should have emergency care and facility for kinetic studies performed in a single center, usually takes about 3 to 6 months. This is the general principle. The first study among the most important probably is the single ascending dose, because this is the first time human beings are administered. Small group of subjects receive a single dose of compound in a proportionally graded manner, usually up to 6 dose levels from the starting dose, with about 6 subjects in each group and two placebos. So about 8 subjects and about 48 subjects would be done. Close safety monitoring and PK pharmacokinetic assessments are done. the pharmacokinetic assessments are up to 6 half-life. So, example, if the half-life from preclinical study is 24 hours, then sample collection would be 24 into 6, 144 hours. So that's for each cohort that is done. Then each cohort is also placebo controlled. So six active and two placebo controlled. Often done in a blinded. After each cohort, you evaluate the safety. Besides the pharmacokinetic, go back to the DSMB. They give you go ahead and only then. So therefore, complete double blinding may not be possible because the evaluation of safety is therefore not possible. Then the multiple ascending dose. Once we know the dose range from the lowest dose, starting dose, to the highest dose, the maximum tolerated dose, then we go ahead with the multiple ascending dose studies, where again pharmacokinetics and dynamics are done with a repeated dosing. So if there was just one dose, here it would be the duration of this dosing depends on the pharmacokinetic parameters that has been found in the SAD. MRSD, the maximum starting safe dose, is usually the starting dose in this study. So, for example, if a SAD had 10 milligram to 160 milligram, and but at 120 milligram and 160 milligram, so you had 10, 20, 40, 80, 160 and 320. But you saw that 80 and 160 there is a saturation. So in that case, you don't go beyond 160 for MAD. You still stick and you start at 20 to go up to 160. So again, that's how we decide the MAD, and also it depends on the duration of the dosing in each cohort. Again, there are 5 to 6 cohorts. Each cohort depends on the steady state value that has been found in the preclinical study. So if the steady state value is around reached at around 7 days, the dosing duration would be around 10 to 14 days, so that you can see the steady state and then also see the maintenance of the steady state. And very importantly, you have to look at the accumulation. So in accumulation index is AUC at steady state and divided by AUC at the first dose. So that is the multiple ascending. So these are the two most important studies, first in human studies, which decide on the further. So in fact, the proof of concept study, the first patient study that is done, is a replica of the MAD study, which means that the dosing would be safe here. It was 14 days, same cohorts, 14 days, but in patients. So first in healthy subject, then the first in proof of concept would be similar to the MAD. So MAD is very important for first in patient study, whereas SAD is very important for first in human studies. Parallel group designs are often obtained because it is more convenient, practical, and each group crossovers will take more time and so that it serves their own control. So in SAD and MAD, usually it's a parallel design which is employed. Also, if it is a biological product, antibodies, if you do a crossover, will interfere with the pharmacokinetics, and therefore parallel studies are also also employed there. Very important study is a fasting and fed study, because food in many drugs, as you know, causes changes in pharmacokinetics, and to evaluate that rate, extent, and bioavailability because of the food, the fed studies are done. Typically, single dose crossover study as a part of the single ascending dose. So one of the most optimum dose, which is expected to be the therapeutic dose, that cohort you do crossover. Say example, if I was talking about 10, 20, 40, 80, 160. So 40, suppose the therapeutic dose. So 40 group patients in SAD, subjects in SAD are crossed over to the fed arm, where food and drug are given, and there the effect of food is considered. So that is how the fasting and fed studies are done. Subsequent studies are the mass balance studies, where elimination and excretion is often the radioactive material are used to trace the drug throughout the kidney and liver. Sometimes you might also want to have another formulation of the IND. So if you have a tablet, you want to have a suspension. So you do a comparative bioavailability study. So those are also part of the IND preparation. Renal impairment and hepatic impairment are two most important, because this is as practical. Again, it goes into the prescribing information. It's a practical situation, and the effect of renal impairment on drug clearance, dosage recommendations in various stages of renal impairment are taken. Effect of hemodialysis on drug exposure is done. Two types of studies: a standalone study, where pharmacokinetics of drugs are in patients with varying degrees of renal impairment, mild, moderate, and severe, to the control function group is compared, and the reduced stage design, where two-stage design, whether two extremes. One is a normal renal function and the severe renal function. So these are usually done when the drugs are non-renally eliminated, that is hepatically metabolized or biliary excreted. In these cases, these are done. If there is a change, then the moderate and mild renal function studies are also done. Then hepatic impairment studies also have a similar point, that study of impact of hepatic impairment on pharmacokinetics of new drugs, especially if the drug is hepatically metabolized and eliminated. Typically conducted as parallel group study with healthy male and female volunteers with varying degrees of impairment hepatic function. Whereas FDA and EMA have a different guidances. EMA guideline does not recommend a specific cutoff for value for hepatic metabolism, whereas FDA guideline has a specific recommendation when hepatic impairment studies are not required at all, especially in renally excreted drugs. If it is the drugs are excreted via lungs, there is no need for doing any hepatic impairment studies. So FDA allows those and has those points. I'm mentioning FDA and EMA, although it's an Indian context, but because these need to be incorporated our Indian guidelines to be more specific. Thorough QT study, again, very, very important, because of the cardiac QT interval prolongation. Almost all drugs, every drug has to go through this intense ECG monitoring and compare with the pharmacokinetic and dynamics elements. And the timing of ECG, PK sampling schedule must be coordinated, and usually require a large number of study subjects, double-blind, randomized, single-site crossover studies with 4 treatment arms: placebo 1, positive control, moxifloxacin 400 milligram IV standard used, therapeutic dose of investigational drug, and supratherapeutic dose of investigational drug. So that's how the TQT studies are done. Very important is the drug interaction studies. Why it is important? Because in real practice, no drug is given alone. There it is given along with multiple drugs. And very, very important where concomitant administration is common, such as tuberculosis, such as HIV, where multiple drugs are. So where the drug interaction studies will have interactions between, say, example, HIV. So the investigational drug and other HIV drugs, investigational drug and other drugs prescribed in HIV, such as rifampicin, such as antihypertensive, such as, and there is a clear-cut guidelines in FDA where which drugs have to be given, have to be done. So commonly with a strong inhibitor and a strong inducer of P453A4, and then adverse event monitoring and pharmacokinetic changes are these are typically crossover studies, and you have there's a washout, and the same subjects go on to the second drug, and then those subjects are continued for the the first drug to be re-added, and then there is a combined kinetics are seen. Just an example, bosutinib, a JAK inhibitor, and has it's a typical CYP3 substrate. Ketoconazole increases
2 minutes.
Increases by 90% and 9 times, whereas rifampicin decreases by 93%. Okay. ADMA studies are used for again absorption, distribution, metabolism, elimination. Again, I'm not going into the details, but these are also conducted. So finally, the desirable clinical pharmacology properties of a drug: absorption, high absolute bioavailability with low variability, linear pharmacokinetics, AUC Cmax not significantly affected by food, pH altering medications, grapefruit alcohol. Distribution reaches a target site of action immediately, and at effective non-toxic concentration, not significantly bound to plasma protein, extent of plasma protein binding not concentration time dependent, metabolism and excretion not. These are ideal properties of which should be there in a IND. Not extensively metabolized, not exclusively metabolized by CYP450, clearance not highly variable, not a narrow therapeutic index does not prolong QT interval, not a significant inducer of CYP3A, PGP, but this does not happen. Most of the drugs have something or the other, and these are the blue areas are the ones where the phase 1 studies impact. So in phase 1 studies are not unimportant. These are very important because if you can see 70% of the prescribing information which goes to the doctors who are prescribing the drugs are affected by the phase 1 studies. So although you have healthy volunteers, uniform subjects, only in patients in case of anti-cancer drugs, you are excluding a lot of healthy volunteers, lot of subjects which are not healthy and who have drugs of abuse and alcohol. But still, the data is very important. Informed consent is extremely important because nothing is known about the drug, only preclinical studies. So it has to be more extensive than a routine standard phase 3, phase 2 studies. And the preclinical data is the only thing that you have about the safety. So it has to be explained very, very properly. And phase 1 study sites are called the CPUs, are run by FDA MOH approved CRO. In India, ICMR has recently approved 4 centers. One of them is PGI, SRM, KEM, and ACTREC, I think. These are the 4 centers, maybe sir can tell. So, sorry? The studies are conducted under supervision of trained clinical pharmacologists with 24-hour medical and attention oversight. But difference with the BAB centers is you need a on-call cardiologist at all time, on-call super specialists such as nephrologists if there are nephrotoxicity. So depending on the toxicity, you need such super specialties, and volunteers are paid an inconvenience fees. Inpatient stay should be there. Continuous and periodic ECG monitoring is extremely important. All just like in any fully functioning critical care should be. And what is deficient in India today is the bioanalytical laboratories, which is, although there are clinical facilities, none of these centers have which are approved by ICMR has any bioanalytical analytic. No, biological method development is very difficult for INDs, and more emphasis has to be done on that because that is what decides whether the drugs succeeds or fails.
Please wind up now.
Yeah. So this is the last thing. The challenges are in India that limited choices for clinical facilities, limited bioanalytical facilities, lack of experience with institutional ethics committees, most of whom are experienced in the phase 3, phase 2 clinical, late phase clinical trials or phase 4 clinical trials. Subject availability is very difficult. Most of them know about BAB studies, but phase 4, getting those 48 volunteers is a Herculean task compared to 300 volunteers in say BAB studies. Inadequate guidelines. Still, the guidelines are, if you look at the guidelines, there are, just, the pointers are there. What exactly comes in this, the data has to be more in detail in terms of talking of the CDSO guidelines. And there are mention of all the parameters, but it has to be more. Yeah. So again, conclusion, the conducting first in human studies of new drug involves many complex issues, but it's a multidisciplinary. It is not just clinical pharmacologists, it is toxicologists, statisticians, pharmacists, pharmaceutical chemists, and also clinicians. Primary concern must be the safety of the study participants. Selection of study subjects, design in initial dose selection, dose escalation strategies are largely dictated by character of the investigational medicinal product. Implementation is done after strictly maintaining scientific, regulatory, and ethical obligations. Thank you very much for your patient hearing.
So just wait for 1 minute. We will felicitate you.
He can also join, sir. Thank you, sir.
Good evening to all. I thank the organizers for providing me the opportunity to talk about adaptive clinical trials. Here, I'm not going to talk about a lot of theoretical aspects of adaptive clinical trials because that can be read from any review article. Here, we are here to share our own experiences in conducting adaptive clinical trials, that too in academic settings, academic clinical trials. Of course, I would definitely add up certain theoretical parts also. I'll try to stick to 15 minutes. Of course, it is not at all sufficient to discuss even the basics of adaptive trials, but still I'll try to manage. So, So for timing purposes, I'm going to skip the clinical trial definition from WHO. However, let us see what an adaptive clinical trial is. So when we look into the various publications of clinical trials, it's usually traditional fixed sample design, wherein the trial is designed and it is conducted and analyzed without changing the protocol. The protocol, I mean, of course, it's not that without changing the protocol does not allow any flexibility in changing the way the trial is executed. Whereas in an adaptive design, as the trial proceeds, the protocol gives the opportunity for us to update the designs and then refine the study so that the objective is achieved. Okay. So when we, so this is nothing but again I'm stressing that adaptive design allow a change in the course of the study based on its performance in according with the pre-specified rules. So that is more important. Whatever adaptations which we plan has to be mentioned properly in the protocol. So when we talk about the various categories of clinical trials, if we look into the publications, the adaptations are usually applied to parallel designs clinical trials. And it's not, I'm not telling that it's not applied to others, but mostly it is in the parallel designs. And when we talk about the other aspects of design, such as randomization, allocation, concealment, blinding, control, single or multi-center, it is usually applied on the randomization levels. Others are usually fixed. Now, there are various forms of adaptations during the conduct of a clinical trial. However, even though the list is more, I'll just enlist the important or very often used adaptations in an adaptive clinical trial. The first is the group sequential testing. Second is adaptive randomization. Third is continual reassessment. We have experiences in all these three adaptations. Then we have sample size re-estimation, multi and multi-stage, and population enrichment. So these are the things which we can discuss. So when we talk about the group sequential testing, it's nothing but scientific explanation for interim analysis. It's our scientific, when the interim analysis is explained in a very, with a deeper knowledge, it becomes group sequential testing. So basically what happens in the group sequential testing is we will perform interim analysis to assess for efficacy or futility, that is efficacy whether the drug is working or not, futility whether the drug is not working, and the safety aspects of a investigational product. So when we talk about the group sequential testing, the backbone of a group sequential testing falls with the alpha spending. Because of the lack of time, I would recommend you all to Google this and what alpha spending is. Basically, alpha spending follows these two algorithms. We can choose any of those two. Of course, there are other algorithms also. That is, we have Pocock functions or Pocock spending and O'Brien-Fleming function or O'Brien-Fleming spending. So basically, not only alpha spending, even beta spending in an adaptive group sequential testing also follows this algorithm. So when we talk about alpha spending, it is usually assigned for the efficacy outcome or efficacy testing. If we assign beta spending for futility testing, okay. Now this is our first experience, not first, second experiences in adaptive clinical trial. One of our PG student is Dr. Gayatri, where we compared a 4-drug regimen to a 3-drug regimen in the management of nausea and vomiting. So this is how we designed with using the O'Brien-Fleming function in defining both the efficacy alpha spending boundary and the futility beta spending boundary. So basically on the y-axis you can see the sample sizes. That is, in the study, the total sample size was 94. However, we planned the interim analysis at the end of recruitment of 44 and 70. And on the y-axis, it is the critical value or the z-value, to put it simpler. So whenever the z-value does not cross the boundary, we will proceed further. Whenever the z-value crosses the boundary, be it on the efficacy side or the futility side, we will stop the study. In this study, we found that our experimental regimen was actually not working in the second interim analysis itself. So it crossed the futility boundary, and then we had to stop the study. Then the second adaptation is the adaptive randomization. So adaptive randomization can be of either frequentist or the Bayesian approach. This was also tried in one of our thesis. What the principle behind adaptive randomization is to reduce the exposure to the ineffective treatment, because that this is more ethical. This has more ethical value. Then the procedure is the change in the allocation ratio based on the response at interim analysis. Setting will be will be with the help of either the Bayesian or the frequentist approach. However, we did only the frequentist approach in another student's thesis. Again, it is also where the study was designed to compare the various to compare an experimental regimen against the standard of care regimen in the management of chemotherapy induced nausea vomiting by Dr. Madan. So this is how we designed our study, where we incorporated both adaptive randomization and also the group sequential testing in a single study. Here, just to focus only on the adaptive randomization part, here now based on each and every interim analysis, based upon the z-score which we obtained on one-sided test for efficacy testing, we changed the allocation ratio. If it is between 1 to 1.5, the allocation ratio will be 1.5. If the z value is between 1.5 to 2, the allocation ratio will be 2, and if it is greater than 2, it will be 2.5. So the allocation ratio will be changed and the sample size will be recalculated based on this formula. Here we had planned, in the same study we had planned for 3 group sequential testing with the final testing, and in this study also, in the contrary to the previous study, we found the experimental therapy was working much better than the control therapy itself, control therapy in the second interim analysis itself, and we stopped the trial for efficacy. Not only that, at the end of first interim analysis, based on the z value, we changed the allocation ratio from 1:1 to 2:1 based on the z value we obtained for the primary outcome from the primary outcome analysis. So, for example, if we had used the Pocock function for alpha and beta spending in the same study, the graph will look like this. However, we did not use this Pocock function. We used only the O'Brien-Fleming function. So if we actually see the alpha spending, if we add up all the alpha values either in the Pocock or O'Brien-Fleming functions, algorithms, we can see that all these p values add up together to 0.05. So I'll not explain much about it. Now, this is just an example for Bayesian adaptive randomization from a publication wherein the allocation ratio will change after the completion of evaluation of each and every participant. So in this study, we can see that the allocation, that is the area of the colors indicate the allocation ratio after the completion of each patient's evaluation. So we can see that after around 27th evaluation, the allocation ratio shifted so much to the idarubicin plus arabinocyte group. Thereby they stopped, they concluded that the first treatment is very efficacious. Then the third adaptation is the continual reassessment, where what we did, it's usually adopted in phase 1 studies. We helped in designing a phase 1 study using continual reassessmental method on a Bayesian framework, wherein after giving the lowest drug for 2 participants, then on the Bayesian framework, we updated the posterior probability. We actually assumed the prior probability based on the probabilities from the animal studies. So we updated the posterior probabilities, and then we will be examining the which dose will have the posterior probability which will fit our objective. So with this method, we can actually skip the intermediate doses which the model predicted to be safe, and we can also be sure that we are not touching the highest toxic dose unnecessarily. So this is one of the adaptations which we had performed. So basically this is the output from the R programming language, where we can see that after the third dosage, the posterior probability showed the toxicity, probability will be 0.36 for the fourth dose. So we recommended that it should not the fourth dosage should not be tried. It has to be stopped with third dosage, and they had to further evaluate the patients on the third dose only, based to fulfill the regulatory requirements. Now, the next adaptation is sample size re-estimation. This is nothing but, again, it's after at any this will be also combined with our group sequential testing, wherein at the end of each and every interim analysis, the sample size will be re-estimated. The major difference being the sample size being re-estimated here and the sample size being re-estimated due to the change in allocation ratio is, for when we estimated the sample size when the allocation ratio was changed, we assumed that the effect size is always kept constant through all interim analysis, whereas this adaptation will allow the change in the effect size at every interim analysis for sample size re-estimation. Okay, so then multi-arm, multi-stage. So actually this adaptation forms a backbone of many other advanced adaptive designs when it comes to drug development. Basically, be it your seamless phase 2, phase 3 designs or early escape or whatever you call. Basically, they always deploy this backbone where we have this multi-arm, multi-stage testing in the clinical trials. So basically this will be used in the dose finding studies, and to put it simply, the effective dose, the dose which is effective is selected and the evaluation is continued. And the ineffective dose arm is dropped post the interim analysis. So for example, this is the protocol from a published literature wherein they evaluated the effect of telmisartan in insulin resistance in HIV patients. So they initially wanted to analyze the 20 milligram, 40 milligram, 80 milligram of telmisartans together, and they proposed that based upon the interim analysis, either they will directly recommend one dosage to phase 3 studies, or if they're found to be ineffective, they will drop that arm, or if it lies in between, they will continue it further before recommending it for phase 3 studies. So that's what the protocol mentioned when it came to your multi-stage testing. The last adaptation which I want to discuss is the population enrichment. Basically, this allows this population enrichment part will allow even after randomization, where we can decide whether the patient can enter the clinical trial or not. So the best and the simplest example here being the removal of placebo responders. So in one of the published study where the efficacy and tolerability of rizatriptan was evaluated in pediatric 1 minute, sir. In pediatric migraine. So we can see that after after recruitment, we can see that the placebo responders, 100 participants who experienced the response to placebo were removed before randomizing them again into experimental and control groups. So that is about the population enrichment. So the last form of, not last form, it is actually the specialized adaptation usually used in cancer clinical trials, which actually borrows the concepts which have been discussed until now are basket trials, umbrella trials, and platform trials. In basket trials, we have one disease and many drugs will be evaluated for one disease, to put it simply. And in umbrella trials, we have one drug and many diseases will be evaluated. I might be wrong also, because it is usually the other way around. If I'm wrong, bear with me. And in the platform trials, what happens is the drug developer usually develops a platform which will allow the treatment arms to enter and exit at any point of time based on a particular framework. So when we talk about the advantages of the adaptive clinical trials are, first of all, less resources are required. Then trial can be completed early, and limited exposure to suboptimal efficacy in ADRs.
A bundle of papers that is in your hand. Now all about data that is about safety, efficacy, tolerability, and dose finding, dose ranging, all kinds of data are in your hand. Now,
good evening, everyone. I said good evening. Last week I had a similar experience. I was the person at 7:45. So I told the ministry people that I have a happy news. And everyone, they were thinking, what was the happy news? And I said, I'm the last speaker. So anyway, because dignitary are waiting for the inauguration, I'll only speak for 10 minutes, not beyond that. But before I begin, I just wanted to put it as positive because we discuss about curriculum. Just have a look at this data. What is our contribution to original research globally? It's less than 4%. I just told you that take it as positive. So if you take example of a smaller country like Switzerland, you take a car, within 1 hour you're crossing border to France, their contribution is 45%, 39 to 45%. I think we must, because we are from AIMS and PGI, we have more than 700 medical colleges, 1400 university. We must look at this aspect, that how we can contribute originally, okay? So it should go beyond 4%. Now, coming to the data, you know that I'll just brief you that there is a policy to keep the data. If I do an experimental study, regulatory toxicity study, I'm going to keep the data for 3 cycles. So there is a justification for keeping 3 cycles. 3 cycles means 1 cycle is 3 years, and you are going to keep it for 9 years' time. When you plan for a clinical study, you are going to go for 5 years. You're going to keep the data for 5 years. What is the reason for keeping 5 years? Because altogether it depends on which regulatory authority you are going to approach them. If I happen to go to US FDA, EMA, or Brazil, they might say that you have to keep the data for 15 years. So there is a reason to do it, like because there's a vaccine study conducted by ICMR. So when they did a preclinical study, then they switched over to clinical study. The first 5 volunteers, they had a big abscess. So we wanted to go and look at this, preclinical data. Was it in a mice and rat? There is a problem in intramuscular injection. And that is why it is very important to keep the data as long as, you are, product is going, it is there in the market. So you must keep the data. So I'll skip all the slide about how the primary, secondary data and how do you collect it. And definitely these are method for collection when you do the studies. But we have a lot of secondary data also. But there is a principle of data handling. Now, if you look at the regulation, the globally regulations are there. If you take the regulation of US or US FDA, and we have also principle that when you look at the ICMR 2017 guideline, you can say that what are the principles you need to keep the data, like you talk about privacy and confidentiality, conflict of interest. We do not understand. Many of you, like when you ask, do you have a conflict of interest? You might say, we don't have a conflict of interest. But is it an academic conflict of interest, okay, financial, personal, or political? You might have remembered that Lancet had published 2 papers, editorial, on JNK. What is the reason that academic journal, they are writing about JNK? There is a huge political conflict of interest. So you must specify, is it an academic, is it a personal, is it a financial? A lot of people, they understand it is financial. So this is how the responsibility it comes. Like as an investigator, when you conduct a clinical trial, you generate the data, at least you make it a point that you are going to contribute to the society. Is it going to benefit the society? So these are principal are their collaboration, or in case of emergency research, we have a lot of experience during the COVID and regarding the biobanking. Now, some of the factors when you generate the data, that if you say you do studies related to genetic, like if I say I wanted to do a study on DMD on agoral community, so definitely you have to be very, very careful about identity, storage, or transportation, disposable. These are the points that are important. So but otherwise, if you see that specific area, like you say, in case of a psychiatry patient, okay, how data should be maintained, or in case of a leprosy, HIV, tuberculosis, or mental health. So these are the points that are very important. But new area it is coming that, you do a clinical trial in the male, female, and others, transgender. How do you look at this data when you generate the data for lesbian or gay, bisexual, or racial, or a refugee? Okay, so these are some of the ethical issues. I'll not go. But otherwise, if you see that when you collect the data, because now we said that when you talk about data, you talk about dry data, you talk about weight data, you talk about e-data. A lot of people, you might have seen e-toilet. So similarly, when you create a data, there's a e-data. That means you have to create an SOP for keeping the e-data. Okay, so is the file size is same when you store the data? Do you have a mechanism to anti-storage or about the security of the data? We have, experience with one of the institute when people have hacked the data. So that is why it is very, very important that how we are going to keep the data. So that is why data management plans should be educated and how we are going to store the data. Is it physical? When you go to any data storage, dry, wet, or E, it is a control. Like moment you say that nobody can enter in that place, you have a logbook. Why you have entered that? You are maintaining humidity, temperature, fire, pesticide spray, everything has to be maintained. So that is why you are storing the data. Now, it is like we never use, like a lot of people are going for a eCRF in a clinical trial. So in that sense, like you have a lab somewhere in, Singapore, centralized lab. So that is why all these SOP need to be looked at in an international standard. And that is why in clinical trial, when you talk about, data management, so basically how you're going to do it, how you're going to, collect the data, how going to store the data, how you're going to do statistically and submit the data to the regulatory authority. So we have a guideline when you talk about globally, ICH guideline, or you talk about any regulator. I have given an example of UK regulators. So this is what the quality you meant. Like you say LQA, is it accurate? Legible, okay? Then, original. And let me say it is accurate, means LQA plus. What does it mean, LQA plus? That means when a regulatory authority go and visit, that is it done? Because when we go to the place, we do an audit or inspection, basically you wanted to see that whatever raw source data, can I reconstruct the whole study? That is very, and when you talk about any quality system, it has an internal quality and it has an external quality. So all these guidelines, what we follow for a regulatory angle, that can you manage internal quality by appointing, like in clinical study, you have a sponsor who appoint a monitor, or in an experimental study, we appoint a quality assurance team, and that is why it is very important to maintain a quality, and that is what LQA. But many times, that I'll just give you an example that, you say is the data is contemporaneous. What does it mean? I've been to one of these lab in Bangalore. They were doing the studies. And I made an observation that this data is not contemporaneous. They have followed all SOP, all protocol. I made the observation it is not contemporaneous. That means while doing that, they're not recording. They will say they'll record after the completion. So this is very important to look at. So that is why you talk about data integrity. So when you say, when you collect the data, is it a good quality data? Can you rely on the data? So that is why the data integrity is very, very important. And that is why any data you say, can I verify from the source data or the raw data? So this is what we call now the metadata. If you wanted to create a metadata, and definitely this SOP should be there at the international level and global level also. So if you look at that, recently there is a document has been released that you have a data, you say good quality data. Have you done the audit trial? And that is why if you see the clinical trial, there is step by step. Before you write the protocol, while writing the protocol, during the study, after completion of the study. So this is how you are going to have a management plan. And obviously that data management plan should be there. Like you have a model, okay? So you already plan it, how you're going to do it. Many times multinational company, they outsource to the CRO, but they have to follow the SOP. So these are the essential documents need to be followed, and that's how we go for it. And definitely you can have a, e-record, audit trail, or paper record, how you're going to do it, and you can create a database. But one more important point is that one area that when you go for a global trial, maybe you generate India-centric data. Okay, then how you are going to log the data. So that is what. So if you say that any assessment you do, you always make a 3 assessment. No action is indicated, or voluntary action of indicated, or official action is indicated. If you follow the protocol, all SOP, no action is indicated. But if you say there is an honest mistake, there is a voluntary action is indicated. And if you do deliberate fraud, so definitely official action is indicated. So you can take an example that how many deviation is there regarding the data. So these are the example, but you know that when you look at that, we have an experience, I'll not go in the COVID, I'll just skip that, or in terms of pan-India data generation from primary, secondary, so these are the models are there. I'll not go in detail. So, but one thing is that if you have you do a good work, good quality work. So if you refer it to Robin Hood, and auditor go and ask that you have done all good work, do you have a receipt? You have given them money, you help them, you don't have a receipt. So that means if there is no documentation, I always refer it to one of the movie, Dirty Picture. You might have seen Dirty Picture. So in this Dirty Picture, Vidya Balan was asked that, what does it mean film? She said it is entertainment, entertainment, and entertainment. So in GCP or any of the accredited system, it's all depend on documentation, documentation, documentation. Okay, so there is a record violation. We have pan-India, regulation is also. So this is how that nobody will believe if you do not have a documentation. Based on documentation, you need to create a data, and you need to create whatever data you are creating, you need to submit to the regulatory authority. So thank you very much. Jai Hind.
Thank you, Dr. Mehdi. In fact, it is a full
session. Now I request Dr. Devasi Shota sir to please felicitate our speaker, Professor Dr. Vikas Medhi. I request Professor Dr. S.M. Nasir sir to felicitate our speaker, Dr. Anand Srinivasan. Thank you, sir. Sir, please. I request Professor Dr. S.M. Nasir sir to felicitate our chairperson, Professor Dr. Devasi Suta sir. I request Professor Dr. Devashish sir to please felicitate our chairperson, Professor Dr. S.M. Nasir sir. Thank you so much to our respectable chairpersons and speakers for their presence. We have had some incredible session and discussion. So now we'll start our inauguration session after 5 minutes.